Hello, my name is Osama Naga. This presentation is about hematology board review.
Check all the updated information in the third edition 2024-2025.
My objective in this presentation is to discuss the red cell disorders, anemias, and erythrocytosis. White cell disorders, I will discuss the neutropenia, while the leukemia will be discussed in the oncology review video. Platelet disorders, thrombocytopenia, and abnormal platelets, and finally coagulation disorders. Anemia can be classified into two categories: decreased production of red blood cells, for example deficiency of the iron, folic acid, B12, or infiltration of bone marrow with abnormal cells, for example leukemia and lymphoma, or bone marrow failure or toxins exposure. Increased destruction of red blood cells, for example defective hemoglobin, a decreased synthesis of beta globin, for example, or alpha globin, like in cases of thalassemia. Membrane defect, for example spherocytosis. Enzyme deficiency, for example G6PD deficiency, or antibodies directed to the red blood cells to destroy it, like autoimmune hemolytic anemia. Classification of anemia according to the size of red cells. MCV, or mean corpuscular volume, into microcytic anemia, normocytic anemia, macrocytic anemia. Microcytic anemia, the size of the red cell will be smaller than the size of the nucleus of mature lymphocyte in the peripheral smear. Normocytic anemia, the size of the red cell will be similar to the size of the nucleus of mature lymphocyte in the peripheral smear. Macrocytic anemia, the size of the red cell, as you see here, is larger than the size of the nucleus in the mature lymphocyte in the peripheral smear. Very important to know that MCV size varies by age. So in newborn period, the size will be between 95 and 121. So if you have a newborn with MCV 110, this is normal for age, is not macrocytic anemia, Between 6 months and 2 years of age, the size of MCV between 70 and 86. There is a helpful tool you can use to help you to know the lower limit of MCV or upper limit of MCV if you do not have the references handy. So if you have 2 years and above and the MCV less than 70 plus the age, this is microcytic anemia. For example, if you have 8 years old with MCV 71, this is considered microcytic anemia because 70 plus 8 is 78, so less than 78 is microcytic anemia. A normocytic anemia will be MCV more than 70 plus the age less than 100. And macrocytic anemia, the MCV will be more than 100. So this is just a helpful tool in 2 years and above, but otherwise you can use the reference table in Harriet Lane, and also it has the standard deviation above and below the mean. In order to understand and make it easy to remember the causes of microcytic anemia, we need to know the structure of the hemoglobin. Hemoglobin equal heme plus globin. So what is heme? Heme is iron and the protoporphyrin. So we need the iron and the protoporphyrin in order to make heme. So in cases of iron deficiency anemia, there is a deficiency in the iron. This will decrease the heme, and eventually this will decrease the hemoglobin and will cause microcytic anemia. On the other hand, if the iron is available but there is a chronic inflammatory condition, like in cases of anemia of chronic disease, the iron will be trapped in the macrophages, and this will decrease the available iron to make heme, and this will decrease the hemoglobin, and this will cause microcytic anemia. In cases of thalassemia, the globin will be decreased, and when the globin is decreased because of mutation or deletion, this will decrease the level of the hemoglobin, and when the hemoglobin decrease, this will cause microcytic anemia. Also, if you have a decreased synthesis or any disease interfere with the synthesis of protoporphyrin, which is very important to make heme, this will decrease the heme, and when you decrease the heme, this will decrease the hemoglobin and will cause microcytic anemia. And this is a classic example of sideroblastic anemia. So sideroblastic anemia is a problem with the synthesis of protoporphyrin, which is very important for heme production. So why when the hemoglobin decrease, this will cause a microcytic anemia? Because the cell will divide extra division, and as the red cell divide more, it will become smaller, and trying to divide the hemoglobin in smaller cells. So this explains why the deficiency of the hemoglobin or decreased hemoglobin eventually will cause microcytic anemia as the disease progresses. Let's start with this clinical case scenario. This is a 4-year-old boy presents to your clinic for pallor. He drinks 32 to 40 ounces of cow's milk per day. He is pale over the last several days. Vital signs are normal. On physical examination, the sclera is not yellow. No hepatosplenomegaly or lymphadenopathy. The remainder of the physical examination is normal. Complete blood work shows the white count is normal. Hemoglobin is low is 6 and the mean corpuscular volume is very low is 59 and the platelet count is slightly elevated and retic count is low with this low level of hemoglobin. And what is the most likely diagnosis? The key point in this case, this is a 4-year-old boy who is pale, drinking large amount of milk, of cow's milk. Cow's milk can cause direct injury to the intestinal mucosa with continuous micro blood loss in stool, and over time this can cause anemia. Physical examination, there is no jaundice to suggest hemolytic anemia as a cause. Also the rest of the exam is normal. The CBC white count is normal, hemoglobin is low, MCV is less than 74. If we use the formula we used before, 70 plus 4, 74, so it is microcytic anemia. Platelet count is slightly elevated, retic count is low for this low level of hemoglobin. So this is a classic presentation of iron deficiency anemia. So the diagnosis from the history and CBC is sufficient. No need for further lab work to confirm the diagnosis. So you can go ahead and treat directly from the history and by looking at the CBC. So and retest the patient in 1 month. So if the hemoglobin normalized, this is diagnostic and therapeutic. Causes of iron deficiency anemia: nutritional. For example, exclusive breastfeeding with no iron supplementation, lack of iron-rich foods, consumption of large amount of cow's milk, which can cause direct injury to the intestine and micro blood loss, and also interfere with absorption of other foods, and also the cow's milk does not have enough iron. So this is very important to counsel the parents about that. Impaired absorption, you need to know that the iron absorption is from the duodenum. So diseases affecting the duodenum can be associated with iron deficiency anemia, for example, celiac disease. Important cause of iron deficiency anemia is blood loss. For example, GI or blood loss from the GI, for example, cow's milk allergy, exudative enteropathy like in Crohn's disease, Meckel's diverticulum, vascular malformation, parasites, for example, hookworms, genitourinary like excessive menstrual bleeding like in cases of Van Willebrand disease, or hemoglobinuria like in cases of paroxysmal nocturnal hemoglobinuria. Pulmonary Goodpasture syndrome, pulmonary hemosiderosis should be suspected in a child with chronic cough and iron deficiency anemia. Clinical presentation of iron deficiency anemia: pallor, so the child will look pale. Cheilonychia, which is spooning of the nails. Pica is very important, which is desire to eat unusual substance like ice, dirt, etc. Headache, irritability, anorexia, tachycardia, and systolic murmur. Laboratory is very important to be able to identify from the lab the iron deficiency anemia. Low mean corpuscular volume, so the MCV will be microcytic, but remember that in the beginning of the iron deficiency anemia, MCV can be normal, so normal MCV do not rule out iron deficiency anemia. Low mean corpuscular hemoglobin concentration, so the MCHC will be low. Elevated platelet count can be elevated, but in the beginning can be normal. It will be more than 450 like in the previous case. Normal or elevated white cell count. Red blood cells can become microcytic as the disease progresses, and hypochromic and increase in different sizes. And when this happens, also this will increase the RDW, which is the red cell width distribution. Target cells are usually absent. If you see target cells, this is classic for thalassemia. You need to know that iron deficiency anemia can be normocytic in the beginning. This is very important to keep in mind. Classic laboratory finding in cases of iron deficiency anemia, of course, low serum iron. This is iron deficiency anemia, and low ferritin level. This is the best study, this is the best test and most reliable test. When the ferritin is low, this is diagnostic for iron deficiency anemia. But when the ferritin is normal or high, this is not reliable test for iron deficiency anemia anymore, because this can be elevated with coexisting condition like in case of hepatitis or anemia of chronic disease. Elevated TIBC. What is TIBC? Is transferrin. So transferrin is the carrier of iron. Whenever the ferritin is low, the TIBC will be elevated, and just signaling the liver to produce more transferrin to looking for any iron in the circulation to carry it. So normally when the ferritin is low or the iron storage in the bone marrow will be low, will send a signal to the liver to produce more transferrin. So the transferrin will be elevated, which is the TIBC. The retic count will be low because there is no iron to make red blood cells. The Menzer index is suggestive, is not diagnostic, but is suggestive of iron deficiency anemia if it's more than 13. How to calculate? MCV divided by red blood cells in million. For example, MCV in this example equals 64, so it is microcytic, and the red blood cells is count is 5.3, so it's slightly on the higher side. So if you divide the 64 by the 5.3 equal 12, this is less than 13, and this is thalassemia. So there is no problem with the making red blood cells. So in cases of thalassemia, red cell count usually is normal or elevated. But in cases of iron deficiency anemia, the body is not making enough red blood cells, so the red blood cell will be low, so is expected for the Menzer index to be elevated. So MCV here is 72, divide by 4.8, so 72 divided by 4.8 equal 15, which is more than 13. So if it's less than 13, suggestive of thalassemia. If it's more than 13, is suggestive of iron deficiency anemia. This is a peripheral smear of a child with hypochromic microcytic anemia, so the size of the red cell is smaller than normal and with exaggerated central halo or central pallor, and also there is a variability in the size between the cells, and this is consistent with hypochromic microcytic anemia and can be seen or commonly seen in iron deficiency anemia. From the history and physical examination and the CBC, if you diagnose iron deficiency anemia, it is important to start the oral therapy as soon as possible of ferrous salts or ferrous sulfate or gluconate. The dose of iron therapy, of oral iron therapy, is 3 to 6 milligram per kilogram of elemental iron per day. We need to remember this by heart. 3 to 6 milligram per kilo of elemental iron per day. This is the dose of the oral iron. And it's better to advise the patient to take it in empty stomach if it's possible, and to take with acidic juice, like for example orange juice or lemonade. This will enhance the absorption of the iron. The iron is better to be absorbed in acidic media. A common problem with iron is the taste and GI irritability and constipation. Advise the patient to take more water and increase the fiber in the diet. This will help with this problem. Response to iron therapy, is diagnostic and therapeutic. It is very important to repeat CBC in 2 to 4 weeks after starting the oral iron. The first thing we'll correct is the hemoglobin and the hematocrit. If the hemoglobin increased by 1 gram per deciliter or more in 14 days, this is an excellent predictor of successful therapy, and it is diagnostic and therapeutic of iron deficiency anemia. The next thing we'll correct in the CBC is microcytosis. This will be followed by the correction of serum ferritin. Iron therapy should be continued for at least 2 months after the hemoglobin normalized to replenish the iron stores. Discontinue the CBC is normal and repeat the test in 6 months. Blood transfusion, very important, and this is always distractor in the exam. Blood transfusion reserved only for severe symptomatic anemia. Means unstable, means tachycardia, lethargy, respiratory compromise. This is very important to keep in mind. Prevention of iron deficiency anemia is critical. For exclusive breastfeeding infants, they should be supplemented with oral iron. For preterm infants, 2 mg per kilo per day of oral iron by 1 month of age should be supplemented. Full-term infant, the dose is lower, is 1 mg per kilo per day of oral iron from 4 months until the iron-rich food will be supplied. Formula-fed infants, if the formula rich in iron or with adequate amount of iron, there is no need to give or supplement oral iron for full-term infants. Whole milk should not be used in the first 12 months of life. Before 12 months, you should not use or supplement or give whole milk, because this will cause iron deficiency anemia. Limit cow's milk to less than 500 cc per day in children older than 1 year. Iron supplementation for vegetarian, they are largely depending on vegetarian diet. Also, screening for iron deficiency anemia in the well visit at 1 year and 2 years for iron lead is very important. Anemia of chronic diseases. From the name, anemia is associated with chronic systemic diseases, also associated with chronic inflammatory process, for example, systemic lupus, and chronic pyogenic infections. Etiology is because of release of inflammatory cytokines, and this will release the hepcidin from the liver, and this hepcidin will decrease the intestinal absorption of the iron and also will block the release of the iron from the macrophages. So the key word here for this disease is the hepcidin is the one will be stimulated by the inflammatory cytokines and will be released by the liver, will decrease the iron absorption and will block the release of the iron from the macrophages. So you will have iron but will be trapped in the macrophages. So this will decrease the heme production and subsequently decrease the level of the hemoglobin and will cause microcytic anemia. Laboratory finding in cases of anemia of chronic disease: low hemoglobin, low MCV or microcytic anemia, but can be normocytic in the beginning but become more microcytic and smaller cells as the disease progress. Often normochromic anemia, but with the progression of disease will become hypochromic. Low serum iron, because a high percentage of the iron is trapped in the macrophages, and elevated serum ferritin because of two factors, because of associated inflammation and also the high percentage of the iron stored in the macrophages. And whenever the ferritin is high, the TIBC will be low. So, but it can be normal in the beginning, but eventually will be low. So the TIBC or serum transferrin will be low. The classic finding here again, high ferritin level. This is very important. Low TIBC and low serum iron. So low TIBC and low serum iron and high serum ferritin. Treatment of the cause. Recombinant erythropoietin may increase the hemoglobin level and improve well-being in patients with cancer. Another cause of microcytic anemia is thalassemia. As you know, remember, the globin is very important to be able to make hemoglobin. So thalassemia is decreased production of alpha or beta globin. So when you decrease the production of alpha globin is alpha thalassemia. If it's beta globin, will be beta thalassemia. In order to understand how thalassemia develop, we need to know the normal types of hemoglobin. Hemoglobin F is alpha 2 gamma 2. Hemoglobin A is alpha 2 beta 2. Hemoglobin A2 is alpha 2 delta 2. So if you look at here, you have alpha and non-alpha, alpha and non-alpha, alpha and non-alpha. In order to have a normal produced hemoglobin, you have to have the alpha to the non-alpha ratio 1 to 1. Means that you will have to have the level of the production or the rate of the production of the alpha 2 similar to the rate of production of gamma 2 in order to have normal hemoglobin F or stable hemoglobin F. For example, if you have decrease in the alpha, like in cases of alpha thalassemia, the normally produced gamma 2 will accumulate, so you will have gamma 2 plus another gamma 2. This will give you gamma 4. And this gamma 4 is well known as tetramer, and this tetramer will cause destruction to the hemoglobin F. Another example, in cases of beta thalassemia, if you have deficiency of the beta 2, you will have accumulation of alpha 2. So you will have alpha 2 plus alpha 2. This will give you alpha 4. And this alpha 4 is a tetramer, and this tetramer will cause destruction of hemoglobin A. And depending on the level of the deficiency of beta 2, you will have more destruction of the hemoglobin A as much as you have more deficiency of the beta 2. This is how thalassemia develop. So again, you have to have the alpha to the non-alpha pair 1 to 1 ratio. So excess of normally produced type will cause cell destruction. This is how thalassemia develop, and this is the meaning of word tetramer. Tetramer means gamma 2, for example, plus gamma 2 will give you gamma 4. This tetramer, this is abnormal globin, and this abnormal globin will cause destruction and will give you another hemoglobin. Instead of hemoglobin F, it will be hemoglobin BART, and this is the meaning of tetramer. We'll start with the alpha thalassemia. This slide is to summarize how alpha thalassemia develop. As you see here, the alpha globin here is part of each hemoglobin. Normal healthy individual has 4 alpha globin gene, 2 in each chromosome 16. So the severity of the symptoms of alpha thalassemia depending on how many gene or how many alpha globin gene is deleted. For example, if you have one, will not affect the production of the alpha 2 too much, and these patients are asymptomatic. If you have 2 of them, this will cause more decrease in the alpha 2. They may develop anemia, but asymptomatic anemia or mild anemia. So 2 gene deletion can be on the same chromosome or 1 from each chromosome. If they are on the same chromosome, this is called cis deletion. If the deletion on each chromosome, this will cause trans deletion, and this presents with mild anemia and a slight increase in the red cell count, and this is usually treated as iron deficiency anemia and with no response to the therapy because it's a problem with the alpha 2 production. If you have 3, 2 here and 1 here, or 2 here and another here, this will present as 3 gene deletion with excess beta 2. So if you have a decreased production of the alpha 2 here, the beta 2 will combine with another beta 2 and will give you beta 4, which is beta tetramer, and this tetramer will be known as hemoglobin H, and this hemoglobin H will cause severe anemia, and this will be easy identified because of the severity of the symptom. This may be discovered accidentally when they do CBC for any other reason. The next one is 4 gene deletion, so there is no genes to produce alpha 2. So this will present early because there is no alpha 2 to make hemoglobin F. So the gamma 2 will combine with another gamma 2, will make gamma 4, and this gamma 4 will be known as hemoglobin BART, and this hemoglobin BART or this gamma 4 will cause destruction to the hemoglobin F in utero and will present as hydrops fetalis. Let's verbalize what we mentioned in the previous slide. Healthy individuals have 4 alpha globin genes. 4 alpha globin genes, 2 in each chromosome 16. Alpha globin production is reduced to absent, can be 1 gene deletion, 2 or 3 or even 4. Seen more frequently in the South Asian and African ancestry. Diagnosis clinically or with alpha globin chain analysis. Excess beta chain, if you have beta 2 plus beta 2 will give you beta 4, which is tetramer or hemoglobin H. Excess gamma 2, like gamma 2 plus gamma 2 will give you gamma 4 or gamma tetramer, and this will known as hemoglobin BART. So if we have 1 gene deletion in cases of alpha thalassemia, this will be well known as silent trait. So it is asymptomatic. If you do neonatal electrophoresis, you may see 1 to 2% of the hemoglobin bars. If you do later on after war, the hemoglobin electrophoresis will be normal. If we have deletion of 2 alpha globin genes, this will present with alpha thalassemia trait. This is a very common presentation and is always treated as iron deficiency anemia with no response to iron therapy. This presents with mild hypochromic microcytic anemia. They may have mild symptoms or no symptoms at all and found incidentally in CBC done for other reason. If neonatal electrophoresis was done, it may show 3 to 10% of hemoglobin bars. Laboratory finding in cases of alpha thalassemia trait, Menzer index will be less than 13. MCV divided by red blood cells, like in this example, 8 years old with MCV 64 and the red blood cell is 5.3, is slightly elevated. So 64 divided by 5.3 equal 12. This is less than 13. This is suggestive of thalassemia. And if you do serum ferritin in this case, it will be normal, not low. The hemoglobin usually more than 9 gram per deciliter. Normal hemoglobin electrophoresis in the case of alpha thalassemia trait, and this is often, as we said, is misdiagnosed as iron deficiency anemia. So we give them iron. For follow-up in CBC, you will see no difference. It's still hypochromic microcytic anemia because the problem with the alpha gene deletion, not iron. And also, if you do the Menzer index for cases of iron deficiency anemia, it will be different. It will be more than 13, not less than 13. So if it's more than 13, this is suggestive of iron deficiency anemia. And if you do serum ferritin for this child, it will be low. So this will be a diagnostic for iron deficiency anemia. But in the case of thalassemia, the serum ferritin will be normal. So what to do for this case? Alpha thalassemia trait, reassurance. No iron therapy is required. Deletion of 3 alpha globin genes. This will present with severe form of alpha thalassemia, hemoglobin H disease. This may present with mild to moderate hypochromic microcytic anemia associated with splenomegaly, jaundice, gallstones, anemia usually exaggerated by infection, pregnancy, exposure to oxidizing drug. Regular electrophoresis will be normal. If you do electrophoresis in the neonatal period, it may show more than 25% of the hemoglobin bars. So this is the form of disease will not be missed because of the severity of the symptoms. Alpha thalassemia major, this is the most severe form of alpha thalassemia because of deletion of all 4 alpha globin genes. So there is no alpha production. So to remind you, a hemoglobin or fetal hemoglobin is alpha 2 gamma 2, and this is necessary to for the fetus to develop. So if there is no alpha 2, what happened to the gamma? The gamma will accumulate, so you will have gamma 2 plus gamma 2 will give you gamma 4, and the gamma 4 is hemoglobin bars. And when you have lots of hemoglobin bars, this will destroy the hemoglobin F in utero and will cause fetal hydrops, and this is a fetal disease, and the baby will be born dead and with prominent hemoglobin bars in the hemoglobin electrophoresis. So this is the most severe form. Beta thalassemia. How beta thalassemia develop? A normal healthy individual, they have one beta globin gene on each chromosome 11. One beta globin gene in each chromosome 11, as you see here in this figure. And the beta thalassemia develop due to gene mutation. Remember that alpha thalassemia because of deletion. Most commonly beta thalassemia because of mutation, and this will decrease the synthesis of beta globin. So you have 3 possibilities: either normal beta globin, or decrease in the synthesis of beta globin, and we'll mark it here as beta plus, or absent beta globin, or beta 0. So if you have normal beta combined with a decreased beta or beta plus, this will present as beta thalassemia minor. So the idea here, you will have decreased synthesis of beta 2, and this will accumulate more of alpha 2 and will make alpha tetramer or alpha 4, and this will destroy some of the hemoglobin A and will present with a slight decrease in hemoglobin A in electrophoresis. And more important to look at is increased hemoglobin A2 more than 3.5%, and usually will be between 4 to 6%, and this will confirm the diagnosis. However, if it is normal and you still suspect beta thalassemia, you have to look at the iron, because this can be normal if there is concurrent iron deficiency. So it's tricky a little bit, but if it is elevated, this confirms the diagnosis of thalassemia trait or thalassemia minor, increased hemoglobin A2 more than 3.5%. and increase in the hemoglobin F to 2%. This can be increased, however, is not specific. The most important thing to look at is increased hemoglobin A2 more than 3.5%. This is confirming the diagnosis of beta thalassemia minor. In other extreme, if you have beta 0 mean there is no synthesis of beta 2. This will cause accumulation of large amount of alpha tetramers or alpha 4. This will destroy all or most of the hemoglobin A and will present with little or no hemoglobin A and increase the hemoglobin A2 and hemoglobin F. This presents after the first 6 months of life, because the hemoglobin F is protective in the first 6 months. Why? Because hemoglobin F do not have beta 2, so it will be produced normally until it disappears, and when the infant start to depend on hemoglobin A, will be no hemoglobin A, then they will present with severe symptoms after the first few months of life. Let's verbalize what we mentioned in the previous slide. Normally or normal individuals have 2 beta globin genes, one in each chromosome 11. So beta thalassemia develop if the beta globin production is reduced or absent because of mutation, because of genetic mutation. Seen more frequently in Mediterranean and Southeast Asian ancestry. Also can be seen in African American, but generally they have a mild course of illness. Relative alpha chain excess leads to shortened red cell survival and variable splenic sequestration, and this is because of the accumulation of the alpha tetramers. Diagnosis of beta thalassemia is by hemoglobin electrophoresis. Elevated hemoglobin A2 more than 3.5%, usually between 4 and 6%, confirm the diagnosis of beta thalassemia minor or trait. And also you may see increased hemoglobin F in the hemoglobin electrophoresis in cases of beta thalassemia. Beta globin chain analysis is another method for diagnosis. This cannot be diagnosed by electrophoresis in neonate because of hemoglobin F. Hemoglobin F is protective in cases of beta thalassemia in the first 6 months of life. Iron and folic acid or B12 must be replaced or replenished or repleted to have accurate hemoglobin electrophoresis. For example, if you have iron deficiency anemia and you do hemoglobin electrophoresis for a patient with beta thalassemia, the hemoglobin E2 can be normal, and if it's normal, this does not rule out beta thalassemia. It is normal because of concurrent iron deficiency. Very important to keep in mind that in cases of alpha thalassemia, hemoglobin electrophoresis is normal, and this is a key point in the during the exam or even clinically. So if you see beta thalassemia, the hemoglobin electrophoresis is abnormal. In cases of alpha thalassemia, hemoglobin electrophoresis is normal in children and adults. But in neonatal period, the hemoglobin electrophoresis may show the hemoglobin H and hemoglobin parts in cases of alpha thalassemia. But outside the neonatal period, the hemoglobin electrophoresis will be normal in children and adults in cases of alpha thalassemia. This is important to keep in mind. If you have a patient presents with hypochromic microcytic anemia and the diagnosis of beta thalassemia is not clear and you want to make a difference between iron deficiency anemia and the beta thalassemia, you can order a test. It's called the free erythrocyte protoporphyrin. This test will be elevated in cases of iron deficiency anemia or lead poisoning, will be normal in thalassemia. The idea of this test is that in cases of thalassemia affects the globin but does not affect the protoporphyrin or the iron. So the protoporphyrin level will be normal in the cases of thalassemia. But in cases of iron deficiency anemia, you do not have enough iron, so the ratio will be of the protoporphyrin will be higher than the iron and will accumulate and will be elevated in cases of iron deficiency anemia. And this step occurs in the mitochondria also. And if there is anything to affect the combination of the iron to the protoporphyrin, like in cases of lead poisoning, the protoporphyrin also will be elevated. So this is how to make the difference between beta thalassemia and iron deficiency anemia. If the diagnosis is not clear, to order free erythrocyte protoporphyrin will be elevated in iron deficiency anemia, or lead poisoning will be normal in case of thalassemia. Why for thalassemia again? Because thalassemia affects the globin, doesn't affect the protoporphyrin or the iron. Beta thalassemia minor silent or near silent trait. From the name, it is asymptomatic. This smear can be normal, but mostly will be microcytosis, hypochromia, and may show also target cells. Decrease MCV, so it is microcytic. A slight elevation of the hemoglobin A2 and hemoglobin electrophoresis confirm the diagnosis of beta thalassemia minor. 4 to 6% is commonly to see this number. So if it's more than 3.5%, it will confirm the diagnosis of beta thalassemia minor. This is important. Thalassemia intermedia is more symptomatic than thalassemia trait. Laboratory finding is microcytic anemia, hypochromic with target cells, and basophilic stippling on the peripheral smear. Menzer index will be less than 13. Hemoglobin usually between 7 to 10 gram per deciliter. If you do hemoglobin electrophoresis, you will see the elevated hemoglobin A2 and hemoglobin F. Let's verbalize how thalassemia major develop. It is because of variable reduction of beta globin gene production and the excess alpha globin, which is alpha globin tetramers, and this will increase the destruction of red cells and ineffective erythropoiesis, and this will shorten the lifespan of red blood cells and splenic trapping and eventually destruction or hemolysis. Clinical presentation of thalassemia major usually presents after the first 6 months of life because of hemoglobin F. So hemoglobin F is protective in the first 6 months of life. They present with severe anemia and increased iron absorption and subsequent toxicity. So they have actually a problem how to get rid of the iron. So the iron level in their body is high. Pallor, jaundice, fatigue, hepatosplenomegaly. So you cannot miss that. So thalassemia major is very easy to diagnose because of the severity of the symptoms. Skeletal manifestation, typical facial features because of extramedullary hematopoiesis and maxillary hyperplasia, flat nasal bridge and frontal busing, pathological bone fracture. For endocrine dysfunction associated with thalassemia major, hypothyroidism, hypoparathyroidism, diabetes mellitus, cardiovascular congestive heart failure. Laboratory finding in cases of thalassemia major: severe anemia, few reticulocytes, less than 8% compared to the degree of anemia, microcytosis, very small cells with no normal appearing red blood cells in the peripheral smear. You will see numerous nucleated red blood cells. Normally, the red blood cells should not be with nucleus, should be without nucleus. Target cells, as you see here, the increased central halo or the increase in the size of central pallor because of deficiency of hemoglobin in the periphery and the accumulation of the sum of the hemoglobin in the middle, and will give the target cell appearance. Menzer index MCV divided by red blood cells is less than 9. So this is suggestive of thalassemia major. So if Menzer index is less than 13, suggestive of thalassemia trait, and if it's less than 9, is suggestive of thalassemia major. Also, another finding very important in case of thalassemia major, jaundice or indirect hyperbilirubinemia or unconjugated bilirubin will be elevated. Management of beta thalassemia major is by pediatric hematologist. Chronic transfusion therapy is required, and before starting or initiating the chronic transfusion, confirmation of diagnosis is a must. Deferoxamine for iron chelation and to decrease the toxicity of the iron. The diagnosis and the treatment of this one will be not a problem because it will be apparent from the beginning, but the problem is with beta thalassemia trait. Many times will be treated as iron deficiency anemia, and you have to know there is no treatment is required, no long-term monitoring is required. Iron will not improve the anemia. Iron only if iron deficiency occurs. In order to understand sideroblastic anemia, we need to go back to this point again: hemoglobin equal heme plus globin. In order to make heme, you need protoporphyrin and iron. If you decrease the protoporphyrin synthesis, you will decrease the heme, and when you decrease the heme, you decrease the hemoglobin and will cause microcytic anemia. So this step of combination of the iron and protoporphyrin occurs where in the mitochondria, and the synthesis part of the synthesis of the protoporphyrin occurs in the cytoplasm of erythroblast. This process in the bone marrow. So if you have decreased synthesis of protoporphyrin, what happened to the iron? The iron will accumulate where in the mitochondria. Without protoporphyrin, the iron cannot leave and make heme. So the iron will be trapped in the mitochondria around the nucleus and will give you a ring. A ring is called sideroblast. It's called sideroblast ring around the nucleus in the erythroblast in the bone marrow. You cannot see that in the peripheral smear. It has to be a bone marrow biopsy in order to diagnose the sideroblastic anemia and to see the sideroblastic ring. So the more the deficiency of protoporphyrin, and the iron will keep coming to the mitochondria and cannot leave and will be trapped and will be surrounding the nucleus and will give the sideroblastic ring. So defective protoporphyrin synthesis occurs where in the mitochondria, and also there is an enzyme is called the ferrochelatase, combine the iron to protoporphyrin. Lead poisoning also decrease or affect the ferrochelatase and will affect the combination of the iron to protoporphyrin, and in this case also the iron will be trapped in the mitochondria, cannot leave without protoporphyrin, and will give you sideroblastic anemia and ring appearance around the nucleus. That's why the lead poisoning also can cause sideroblastic anemia. So the sideroblastic anemia can be cause of congenital, like for example deficiency of this enzyme is called the ALAS or aminolevulinic acid synthase. This is a very important step in the synthesis of protoporphyrin. If you have deficiency of this enzyme, will affect the synthesis of protoporphyrin. Or another syndrome is called the Person-Marrow pancreas syndrome, is associated with sideroblastic anemia and pancreatic enzyme deficiency. Lead poisoning, as we mentioned, vitamin B6. Vitamin B6 is a cofactor for ALAS, and if you have deficiency of vitamin B6, also will decrease the protoporphyrin synthesis and eventually will cause anemia, which is sideroblastic anemia. For example, patient treated for TB with isoniazid, for example, can cause sideroblastic anemia because of vitamin B6 deficiency and decreased synthesis of protoporphyrin. And this is how to understand the mechanism. So the mitochondria surrounding the nucleus, it will have a lot of iron trapped in the mitochondria. That's why we'll give you a ring. In this way, you will understand how the sideroblastic anemia develop. Also, to understand the lab, the more iron accumulate in the mitochondria will destroy the mitochondria and will cause lysis, and this free iron will be taken by the macrophages, and this will increase the serum ferritin, will increase the serum iron, and will decrease the TIBC. So this is the expected lab finding in cases of sideroblastic anemia. So in this case, in case of sideroblastic anemia, the patient will present with microcytic anemia, and this is the expected lab finding. As we said, increased serum ferritin because of increased serum iron, and all this iron will be taken by the macrophages, and this will increase the ferritin. And whenever the ferritin is high, the TIBC or serum transferrin will be low, and also increase the serum iron. So this patient will be overloaded with iron because they cannot use it to make heme because of deficiency of or decreased synthesis of protoporphyrin. And whenever the serum iron is high, also the percent of saturation or the number of iron combined to the transferrin, it will be elevated. So this is the expected lab finding in cases of sideroblastic anemia. And then when you do bone marrow biopsy with a specialist stain, it's called the Brochet stain, it will show the iron around the nucleus as a ring. And this iron presents where? In the mitochondria. In the mitochondria. This is important. Let's read what we mentioned before. Causes of sideroblastic anemia is congenital, like for example ALAS enzyme mutation, which is aminolevulinic acid synthase mutation. Lead poisoning, we know now why the lead poisoning, because the lead poisoning decreased the combination of the iron to the protoporphyrin in the mitochondria because of inhibition of enzyme called ferrochelatase. Vitamin B6 deficiency, like if a patient is taking if he's taking isoniazid for treatment of TB, because this is a cofactor for ALAS, and if there is no ALAS, this will decrease the synthesis of protoporphyrin. This will cause ineffective erythropoiesis caused by iron deposition in the erythroblast in the bone marrow. This will cause mild to moderate hemolysis, and as a result of the hemolysis, you will have lots of iron, and this iron will be taken by the macrophages, will be elevated, and this will decrease the TIBC. And will present with microcytic anemia, but can be normocytic also. This is important to keep in mind. So very important to know the variation so you do not miss the diagnosis. And in the bone marrow biopsy, you will see the ringed sideroblast in the bone marrow, as you see here around the nucleus, with a special stain called the Brochet stain. The iron will appear as blue dots around the nucleus of erythroblast in the bone marrow. Very important to know that sideroblastic anemia is a risk for acute leukemia. Lead poisoning is a very important cause of microcytic anemia, and the best way to confirm the diagnosis of lead poisoning is by the venous sample showing high level of lead level. Also another test is free erythrocyte protoporphyrin, and we explained this test in the previous slide. Basophilic stippling in the peripheral smear of red blood cells, as you see here, small blue dots in the red blood cells representing ribosomes, stained with blue. As you see here, basophilic stippling is because of the toxic effect of the lead poisoning during the production of erythrocyte in the bone marrow. But this can be found with other diseases, and also sometimes it can be seen in healthy individual. So the best test is a high serum lead level. So this is suggestive but not diagnostic. Ringed sideroblast, this confirms the diagnosis of sideroblastic anemia if you do a bone marrow biopsy. Lead level, when it reaches 45 to 69, this patient will be eligible for oral chelating agent, and if it reaches 70, this patient need to be hospitalized. At all the time, all the patients, they must have monitoring for the environment and close follow-up. The lead poisoning is a very important cause of microcytic anemia. Also, screening for lead is recommended at 1 year and 2 years of age with lead and hemoglobin. Is very important to remember that. This slide is to summarize the clinical approach to a patient to present with microcytic anemia. After confirmation that the MCV is lower than the normal limit for age, we will calculate the Menzer index. If the Menzer index is more than 13, this is suggestive of iron deficiency anemia. So we'll ask this question: is the anemia mild? Are the history and the indices consistent with iron deficiency anemia? If it's yes, we will treat the patient with oral iron and we'll retest the patient 1 month. If the hemoglobin is correcting, this is diagnostic and therapeutic, and we'll counsel the patient for cow's milk consumption, and we'll add another 2 months of oral therapy to replenish the iron storage. If the answer to this question is no, we will need more studies, iron studies and lead level. The first one and the most common one is iron deficiency anemia when the ferritin level is low. This is confirmed, and this is the best test to confirm the iron deficiency anemia is serum ferritin when it's low. And whenever the serum ferritin is low, the TIBC will be elevated and low serum iron. This is consistent with iron deficiency anemia. So we'll go ahead and treat the patient and we'll retest the patient a month. If the patient is responding, we'll do the same step. If the patient is not responding, we need to the iron therapy, we need to find out if there is any source of bleeding like GI bleeding, and if it's positive, refer to pediatric gastroenterology. The next possibility is high serum ferritin, lower low TIBC and low iron. This is consistent with anemia of chronic disease, and we will treat the underlying cause. The next possibility is high serum ferritin, low TIBC, and high iron. So this is unique about sideroblastic anemia, that the iron will be elevated. So to confirm the diagnosis, bone marrow biopsy, and will show the ringed sideroblast in the bone marrow biopsy. And if this is positive, we'll check the lead level, and we'll also check other causes if the lead level is normal for causes of sideroblastic anemia. So if the Menzer index is less than 13, this is possibility of thalassemia or suggestive of thalassemia. If the iron study is normal and the electrophoresis is normal, this is alpha thalassemia. If the iron study is normal and the electrophoresis is abnormal, showing elevation of hemoglobin A2 more than 3.5, this is beta thalassemia trait. This is how to approach a patient presents with microcytic anemia. We'll start a new section, macrocytic anemia. Macrocytic anemia means MCV more than 100 in a child older than 2 years of age. Very important to know that in newborn infants, normally the MCV will be more than 100. So if you see MCV in a newborn 110, for example, this is normal for age. We have to know also that macrocytic anemia can be megaloblastic or non-megaloblastic. Megaloblastic, the cause will be folic acid or B12 deficiency, and non-megaloblastic other causes. Folic acid is very important for DNA precursor synthesis in the erythroblast. So when there is no folic acid, this will affect the synthesis of the DNA in the precursor synthesis in the erythroblast, and the cell will divide less. As you know, the erythroblast, the more it divides, the more become smaller. So when you have a deficiency of the folic acid, the cell will divide less and will stay large, and that's why the folic acid deficiency will cause macrocytic anemia. Also, B12 is very important to demethylate, or to take the 5-methyl group to combine it with the homocysteine to make methionine. So deficiency of the vitamin B12 will decrease the loss of this methyl group to form the folic acid, which is necessary for DNA precursor synthesis. So again, if you affect the DNA precursor synthesis, this will decrease, or you will have less division in the erythroblast, and the cells will stay large, and this will eventually cause anemia, and is well known as macrocytic anemia. The way to know if the red cell is small or large by comparing the size of the red blood cell to the size of the nucleus of mature lymphocyte. As you see here, this cell is larger than the nucleus of the mature lymphocyte. So this is a preference meal of macrocytic anemia, and this can be caused by folic acid or B12 deficiency. Very important to know the possible causes of folic acid deficiency can be nutritional. The sources of folic acid: leaves, vegetables, fruits, and also animals. And the body stores of folic acid, you need to know, is only 2 to 3 months, different than B12. So folic acid is very short time to be stored in the body, so you need always to be supplied with folic acid. Inadequate intake during pregnancy, growth in children, and also in cases of hemolytic anemia, you require more folic acid. Goat milk consumption, I make it in different color because I love it in the board. For infants, they are consuming goat milk. Goat milk sometimes given to the infants because of reflux, but the goat milk is deficient in folic acid, so this can be associated with folic acid deficiency. Decrease folic acid absorption, like for example removal of ileum, or inflammatory bowel disease, like in cases of Crohn's disease. Anticonvulsant medication, like for example phenytoin, congenital dihydrofolate reductase deficiency, and drug-induced classic example methotrexate. Clinical presentation of folic acid deficiency is megaloblastic anemia, glossitis, irritability, inadequate weight gain, chronic diarrhea, hemorrhage from thrombocytopenia in severe cases. As you see here, there is no neurological symptom. Different than B12 will be associated with the same but with neurological manifestation. MCV here will be more than normal, so MCV will be more than 100. If you see here, this is a nucleus of mature lymphocyte. Here the size of the red cell is larger than the nucleus of the mature lymphocyte. Also, if you look at the neutrophil, the nucleus will be hypersegmented, more than 5 lobes. 1, 2, 3, 4, 5, 6, 7. So it's more than 5 lobes. This is unique about B12 or folic acid deficiency. Elevated LDH, low serum folic acid. This is very important to measure when you suspect cases of macrocytic anemia. You need to do folic acid and B12 level. High serum homocysteine because of lack of methylation and decreased conversion from homocysteine to methionine. Hypercellular bone marrow. Treatment of folic acid deficiency, you need to rule out first B12 deficiency before you start folic acid therapy. Very important to do that, because treating B12 deficiency with folic acid will correct the macrocytosis, but the neurological symptom will keep getting worse. So it's very important to rule out B12 before you treat folic acid deficiency. Folic acid will be 0.5 to 1 milligram per day, IV or oral. Hematologic response can occur within 72 hours. This is diagnostic as well. Treatment continued for only 3 to 4 weeks. Maintenance dose is 0.2 milligram daily. If you compare the body store of B12, the body store of B12, it takes years to finish the B12 from the body, compared to folic acid is only a couple months, but for the B12, 3 to 5 years to finish all the body stores of B12. Sources is only animal source. There is no other source of B12 other than animal products. So etiology, inadequate intake of B12, like strict vegan, means no milk, no egg, no any source from the animal, exclusive breastfed and maternal vegan diet at the same time. Removal of terminal ileum for any reason, or disease of terminal ileum like Crohn's disease, or even a worm or tapeworm affected the absorption of B12 in the small intestine, like Diphyllobothrium latum. Absence of B12 transport to protein and stomach intrinsic factor is very important for B12 to be absorbed from in the terminal ileum to be combined with intrinsic factor from the stomach. Clinical presentation of B12 deficiency: weakness, fatigue, failure to thrive, irritability, pallor, glossitis, vomiting, diarrhea, icterus or jaundice. Neurological manifestation: this is what will make the difference between B12 and folic acid. B12 is associated with neurological symptoms. The reason is really unclear, but it is suggested because of B12 deficiency will decrease the conversion of methylmalonic acid to succinyl-CoA. So accumulation of methylmalonic acid will in the central nervous system will affect the myelination process. So this can be associated with subacute combined degeneration of spinal cord, impaired vibration sense, ataxia, paresthesis, developmental regression, and neuropsychiatric changes. Laboratory finding in cases of B12 deficiency, macrocytic anemia similar to folic acid, and also with megaloblastic changes and hypersegmented neutrophils more than 5 loops. Elevated LDH, normal iron and folic acid, but B12 will be low. Increased methylmalonic acid in urine, increased homocysteine, low reticulocyte count for the degree of the anemia. In cases of pernicious anemia, the test to do is anti-parietal cell antibody. This will be positive. A classic Schilling test is not recommended or is not used anymore. Treatment of B12 deficiency, parenteral administration of B12 1 mg daily with neurological involvement continue for minimum of 2 weeks. Then the maintenance of monthly intramuscular vitamin B12 for life. Diagnosis and the treatment of tapeworm infestation, celiac disease, Crohn's. You need to treat the underlying cause. This slide is to summarize how to approach a patient with macrocytic anemia. You need to order peripheral smear. If the peripheral smear shows hypersegmentation of the neutrophil more than 5 loops with macrocytosis, MCV more than 100, this is megaloblastic anemia. If the peripheral smear shows macrocytosis with normal neutrophil with no hypersegmentation of neutrophil, this is non-megaloblastic anemia. The next step here to order retic count. If the retic count is elevated, you need to evaluate for possibility of hemolysis or hemorrhage. If the retic count is low, you need to evaluate for possibility of hypothyroidism, hepatic disease, or alcoholism. In this case, you need to treat the cause. If there is no cause can be found, you need to refer to pediatric hematologist. In case of megaloblastic anemia with macrocytosis and the hypersegmentation of neutrophil more than 5 loops, you need to test the level of folic acid and B12 together. Then if you have low vitamin B12, you need to treat and retest again to ensure response to therapy. Also, you need to consider possibility of underlying causes, for example, pernicious anemia, ileal disease, or tapeworm infestation. In case of low folic acid, you need to confirm that B12 is deficient, is not deficient, B12 is normal. Then when B12 is normal, you can go ahead and treat with folic acid and retest the patient again and provide dietary counseling. If both of them are low, in this case, you need to refer to pediatric hematologist for management and possibility of bone marrow disorder. Person-Marrow pancreas syndrome is a variant of sideroblastic anemia. The clinical presentation: macrocytic anemia in neonatal period, elevated alpha-fetoprotein, neutropenia, thrombocytopenia, failure to thrive. Also, the Person-Marrow pancreas syndrome presents with pancreatic fibrosis, insulin-dependent diabetes mellitus, exocrine pancreatic deficiency, muscle and neurological impairment. In laboratory finding, if you do bone marrow biopsy, you will see the ring sideroblast, which is the trapped iron in the mitochondria surrounding the nucleus of the erythroblast, and you will see also vacuolated erythroblast and myeloblast. The keyword for this disease: sideroblastic anemia with pancreatic dysfunction. A rare cause of non-megaloblastic macrocytic anemia is Diamond-Blackfan anemia, is congenital hypoplastic anemia. The primary defect in the erythroid progenitors in the bone marrow. Clinical presentation: profound anemia manifested by 2 to 6 months of age. More than 50% they have congenital anomalies, for example, short stature, craniofacial dysmorphism, triphalangeal thumb, or abnormalities with the thumb. So the key word for this disease: non-megaloblastic macrocytic anemia with congenital anomalies. Look for this word in the keyword in the exam: triphalangeal thumb or abnormality with the thumb. Laboratory finding in cases of Diamond-Blackfan anemia: macrocytic red blood cells with no hypersegmentation of neutrophil. And if you test B12 and folic acid, they will be normal. Increased adenosine deaminase activity in most patients. Decreased red blood cells precursor in the bone marrow. Elevated serum iron, and this is a problem for this patient, the high level of the serum iron. Normal bone marrow chromosomal studies. Normal to low retic cell count. Negative PCR for parvovirus B19. Treatment of Diamond-Blackfan anemia is a steroid, iron chelating agents if transfusion dependent, stem cell transfusion for who do not respond to corticosteroids, and after several years of red blood cell transfusion. Prognosis: median survival more than 4 years. We'll start a new section: normocytic anemia. Normocytic anemia means MCV is more than 70 plus the age and less than 100 in a child older than 2 years of age. The first disease we'll discuss in normocytic anemia is transient erythroblastopenia of childhood. This is the most common acquired red cell aplasia in childhood, more common than Diamond-Blackfan anemia, which is congenital hypoplastic anemia. But remember, this is macrocytic. For transient erythroblastopenia of childhood is normocytic. The etiology is a transient suppression of red blood cell production, often noted after viral infection and with no evidence of parvovirus B19. Common age of presentation between 3 months and 3 years of age, most commonly more than 12 months of age. More common in males, the most common presentation is asymptomatic, no symptoms despite the severity of anemia and a very low level of hemoglobin. The patient may present with gradual increase in pallor. Uncommon presentation is increased fatigue or decreased energy, breath holding spells. Laboratory finding in cases of erythroblastopenia of childhood: normocytic anemia, MCV will be normal, hemoglobin can be very low down to 2, and the reticulocyte count will be decreased. The bone marrow biopsy rarely needed, but if it's done, it will show erythroid suppression. Normal adenosine deaminase level. In cases of Diamond-Blackfan anemia, the MCV will be elevated. Macrocytic anemia, also the EDA will be high. Also, Diamond-Blackfan anemia will be associated with congenital abnormalities, for example, short stature, abnormal facial features, and abnormal thumb. The treatment here from the name transient, so is reassurance. Despite the very low level of hemoglobin, reassurance, and usually the patients will recover within 2 to 3 months. Occasionally and rarely transfusion is necessary. Before we proceed further in the hemolytic anemia, I would like to explain the reticulocyte count. Reticulocyte is immature red blood cells. They represent about 1% of the red blood cells in the body. It appears without nucleus, and it has blue dots. This represents the ribosomal RNA. When it matures, it will become normal red blood cells with central pallor. What is the significance of the reticulocytes clinically when we see it in the peripheral smear? If someone has severe anemia and you see the retic count is high, you know that the bone marrow is working, is compensating to make more red blood cells. But what we need to know that in cases of anemia, the retic count will be falsely elevated. So we have to do correction in order to get the real value of the retic count. For example, if you have patient with anemia and the retic count is 4% and the hematocrit is 25%, so how to do the correction? The correction will be percent or the percent of the retic count or the reticulocyte count, like in here will be 4, and the patient hematocrit like here will be 25, divided by the normal value of hematocrit, so will be 4 times 25 divided by 45 will be equal 2.2. So the real value of the retic count here is 2.2%, not 4% for this patient. So if you have corrected retic count more than 1.5%, this suggests hemolysis or blood loss. This means that the bone marrow is trying to compensate to produce more more blood cells to compensate for this anemia. I would like to explain 2 points before we start. The hemolytic anemia is intravascular hemolysis and extravascular hemolysis. Intravascular hemolysis, it means the hemolysis within the blood vessels, and when the red blood cell break will release hemoglobin. Some of this hemoglobin will combine with the haptoglobin, and this haptoglobin trying to save some of the hemoglobin to save more iron, and most of the hemoglobin will be free in the circulation. So when you do lab, you will see that the haptoglobin level is low in cases of hemolytic anemia. And why? Because it's combined with some of the hemoglobin, and the rest of the hemoglobin will cause hemoglobinemia, and this will be complicated by hemoglobinuria. In cases of extravascular hemolysis, the red blood cells will break by the macrophages in the spleen, liver, and lymph nodes, and no wonder why the spleen will be large. So this extravascular hemolysis will be complicated by splenomegaly. Both cases, they will break the red blood cells and will be complicated by jaundice. Why jaundice? Because the heme is two things, is iron and the protoporphyrin, and the protoporphyrin will be converted to unconjugated bilirubin. So in cases of hemolytic anemia, you will see the patient is having jaundice. Hereditary spherocytosis is autosomal dominant. 25% of the patient do not have family history. The problem of this disease is with the cytoskeleton of the red blood cell. So normally the red blood cell is biconcave shape and central pallor. If there is any problem with the cytoskeleton or any weakness in the cytoskeleton, this red blood cell will lose this shape and will become spherical red blood cell. This can be because of spectrin deficiency, spectrin and anchorin deficiency together, band 3 deficiency, or a protein 4.2 defect. So if the cell becomes spherical, the membrane is weaker, and when these cells goes to the spleen will break it with extravascular hemolysis, and the spleen will keep getting larger. So the problem, or this hemolysis, is confined only to the spleen. So if there is no spleen, will be no problem at all. This patient will live with no problem, with no hemolytic anemia. But the problem is when the spherical cells goes to the spleen, it will break, and this will be complicated by jaundice, hemolytic anemia, and splenomegaly. So removal of the spleen sometimes is the key or the treatment for this disease. Clinical presentation of spherocytosis may be asymptomatic into adulthood. Commonly they present with anemia, pallor, jaundice. The jaundice can be severe during neonatal period, sufficient to require exchange transfusion. Because of a high level of unconjugated bilirubin, the liver will conjugate this bilirubin to make bile, and the excessive production of bile can be complicated with pigment gallstones. Also they may present with fatigue, exercise intolerance, and of course splenomegaly. Patients with blood disorder like sickle cell anemia or spherocytosis, they cannot afford to be infected with this virus, parvovirus B19. So this virus will infect a healthy person. They will have mild anemia and they will recover quickly with no symptom. But in the patients with blood disorder, this may complicate with aplastic crisis, and they will have a profound anemia with hematocrit less than 10%, high cardiac output, failure, hypoxia, cardiovascular collapse, or even death. Classic laboratory finding in case of hereditary spherocytosis is reticulocytosis. Very important, reticulocytosis, because the bone marrow is healthy. There is no problem with the bone marrow, but the problem is with the breakdown of the red blood cells by the spleen. Indirect hyperbilirubinemia, so they have jaundice, and the unconjugated bilirubin will be elevated, and we explained why. High LDH because of the breakdown of the red blood cells. The haptoglobin will be busy with the hemoglobin, so will be low. So low haptoglobin. This is a normocytic anemia. It's not macrocytic, it's not microcytic, and this is unique about hereditary spherocytosis, will be elevated MCHC. So this is the importance of MCHC in cases of hereditary spherocytosis, will be elevated. And a high percentage of spherocytes on the peripheral smear, and this can be confirmed also the diagnosis of hereditary spherocytosis with osmotic fragility test, because the red cell cytoskeleton is fragile and can be broken by hypotonic solution. This is a classic smear or a peripheral smear of a patient with hereditary spherocytosis. As you see here, this is a nucleus of mature lymphocyte, and this spherocyte, you will see it is smaller than the normal red blood cells and with loss of central pallor, and this is the meaning also of increased MCHC. So is a smaller than normal with loss of the central pallor, so is a spherocyte and is smaller than the mature nucleus of the lymphocyte. This is another one. So if you keep looking, you will find a small red blood cells with loss of central pallor and smaller than the mature nucleus of lymphocyte. Treatment of hereditary spherocytosis is folic acid. Folic acid is very important to prevent folic acid deficiency, to be taken on daily basis. And you know that folic acid is very important for erythropoiesis and the division of DNA precursor in the erythroblast. So folic acid supplementation is important. You know that this patient without spleen, they will not have a problem. So the spherocyte will be walking normal, functioning normal, carrying oxygen with no problem. Once it reaches the spleen will break it. So the spleen is the problem. So indication for splenectomy if the hemoglobin is less than 10, means severe anemia, severe reticulocytosis, aplastic crisis, poor growth, cardiomegaly. Some experts do not recommend splenectomy in patients with hemoglobin hemoglobin more than 10 and reticulocytes less than 10%. If you decide to remove the spleen, the patient has to receive vaccination for encapsulated organism, Haemophilus influenza, meningococcus, and pneumococcus, and this should be given before splenectomy. Then this should be followed by prophylactic penicillin, oral penicillin, 125 mg twice a day if less than 5 years, and 250 mg twice a day if is more than 5 years. Partial splenectomy is useful in children less than 5 years. After splenectomy, if you do a peripheral smear, you will start to see Howell Jolly bodies, which is this blue dot in the red blood cell, which represent a remnant of the nucleus was supposed to be removed by the spleen, but because there is no spleen, this remnants of the nucleus will remain in some of the red blood cells in the circulation. Paroxysmal nocturnal hemoglobinuria. This is a patient presents with dark urine. So this is an acquired condition because of hematopoietic cell mutation defect, and this affects all the blood cells. Very important, because this hemoglobinuria give you impression that it affects the red blood cell only. No, actually affects all the blood cells. Red blood cells, white blood cells, and the platelets. So what happened with this disease? This patient, they have mutation with the GPI. What is the GPI? Is an anchoring protein. Anchoring protein connect this protein molecules to protect the red blood cells from the complement, to be broken by the complement. So the GPI, if there is no GPI, will be no C8 binding protein. If there is no GPI, will be no MERL or membrane inhibitor of reactive lysis or CD59. And so if you have defect in that, you will have less of the MIRL or CD59. If you have defect in the GPI, you will have decrease in the decay accelerating factor or CD55. So the cell will be vulnerable to be broken or destroyed by the C3b and C4b or complement. So this will result in intravascular hemolysis, and this is exaggerated during sleep possibly because of the acidosis or because the urine will be concentrated at night. So when you sleep, you retain more CO2, and this will cause respiratory acidosis and will exaggerate this defect and will make the red blood cells more prone to be broken at night. But this can happen anytime, even during the day. But at night is just more exaggerated than during the day. The urine will be darker. Intravascular hemolysis means hemolysis within the blood vessels, and this will present with hemoglobinemia, hemoglobinuria, hemosideриnuria, thrombosis, pancytopenia. The most common cause of death of these patients is thrombosis of hepatic, portal, or cerebral veins, large veins. So this is a summary for the paroxysmal nocturnal hemoglobinuria. And if you want to screen or to test this patient, you can do flow cytometry to test for CD59 and CD55. CD59 and CD55. So if you understand this slide, everything coming will be very easy to absorb and remember. Paroxysmal nocturnal hemoglobinuria most often caused by an acquired intrinsic defect in the cell membrane, which is the GPI as we mentioned, is a deficient membrane associated protein including decay accelerating factor and C8 binding protein. Clinical presentation: nocturnal and morning hemoglobinuria means that the patient will present with dark urine, very dark urine, and even black. Thrombosis and the thromboembolic phenomena is a very serious complication, and they even can cause death. Aplastic anemia may precede the episode of paroxysmal nocturnal hemoglobinuria. So this patient, they can present also with weakness and fatigue. Laboratory finding in case of paroxysmal nocturnal hemoglobinuria: abnormal shaped red blood cells, evidence of hemolysis like any other hemolytic anemia, elevated LDH, hyperbilirubinemia or elevation of unconjugated bilirubin, low haptoglobin because some of the hemoglobin will be combined with the haptoglobin, so the haptoglobin will be low. Also negative COMS test, so is not hemolytic anemia. Flow cytometry will confirm the diagnosis with showing low level of CD55 and CD59. Also positive results on acidified serum hemolysis HAM test or sucrose lysis test. Markedly decreased acetylcholine esterase activity and decay accelerating factor. Treatment of paroxysmal nocturnal hemoglobinuria in acute event, blood transfusion. Use of glucocorticoids is controversial. For chronic cases, eculizumab will prevent the complement binding and decrease hemolysis. Warfarin to prevent the thrombotic complications. This patient may need iron because of the loss of hemosiderin or iron in urine. Sickle cell disease is very important to know by heart. Thalassemia's decreased synthesis of hemoglobin, but sickle cell disease will give you abnormal hemoglobin, well known as hemoglobin S, because of mutation, and this mutation will cause substitution of valine for glutamine at 6th position in the beta globin chain. It is autosomal recessive inheritance. Sickle cell disease occurs because of substitution of valine for glutamine at 6th position in the beta globin chain. So the problem is with the quality of the beta globin, not the amount or the quantity. In thalassemia you will have decreased synthesis, but here you will have abnormal beta globin. This abnormal beta globin, if you have one mutation, it will give you sickle cell trait. It will be not enough amount to cause sickling. And if the two genes are affected, will give you the sickle cell disease because the amount of hemoglobin S will be 90% or more. So when the hemoglobin S exposed to hypoxemia, dehydration, acidosis, the hemoglobin S will polymerize. What do you mean by polymerize? It will aggregate, and when the hemoglobin aggregates in the red blood cells, the red blood cell will change the shape to be banana-like or needle-like structure. And because of the frequent exposure to hypoxemia or stressor, you will have sickling and desickling, sickling and desickling, and over time the membrane of the red blood cell become weak, and the cells start to hemolyze. And the hemolysis occurs extravascular in the liver and the spleen, and or intravascular within the blood vessels, and both they will present with anemia, decrease in hemoglobin and hematocrit, jaundice, which is increased level of unconjugated bilirubin, and this excessive amount of unconjugated bilirubin will be taken by the liver to make bile, and this will increase the risk of gallstones. And also the haptoglobin will try to save some of the hemoglobin to keep some iron, and the haptoglobin will be decreased and also will be associated with target cells. And for the body to compensate for the anemia, the body will try to make more red blood cells in unusual places, like for example the liver or the skull bone and facial bone. In the first 6 months of life or the first few months of life, the hemoglobin F will be protective because hemoglobin F does not have beta globin. So the hemoglobin F will protect the patient with sickle cell disease in the first few months of life. Usually presents after the 6 months of life. And from this idea, they use the hydroxyurea, which will increase the hemoglobin F level to treat pain crisis and manage the severity of the sickle cell disease. On the other hand, there is two forms of the sickle cell disease, either presents with hemolysis or irreversible sickling and thrombosis. So when the cell sickle and does not go back to normal, it will cause vaso-occlusion or thrombosis. And if this vaso-occlusion in the small bone in the hands and feet will present with dactylitis, and this is the common presentation during infancy and in the first 2 years of life. So when you have a child with family history of sickle cell disease or trait and it presents with swelling in the hands and feet, you should suspect the sickle cell disease. And usually this is the initial presentation or painful presentation is dactylitis. Then the next one is autosplenectomy, which is thrombosis or vaso-occlusion in the spleen, and the spleen will start to shrink and will be associated with abnormal function or dysfunction in the spleen, and you start to see the howl jolly body start to appear in the red blood cells in the peripheral smear. Also, they may present with acute chest syndrome, and they present with pneumonia, atelectasis, respiratory symptoms, tachypnea, and this is the most common cause of death in adults. Also, pain crisis. Pain can be anywhere in the abdomen, in the chest, in the back. Renal papillary necrosis, and they present with hematuria and proteinuria. This is a summary how the sickle cell disease presents. Just again, if you have one mutation, will be sickle cell trait, and usually they are asymptomatic. If you have two mutation, you will have the sickle cell disease with hemoglobin S 90% or more, and this is the one they will have a problem all the time. Clinical presentation of sickle cell disease usually diagnosed in neonatal screen. Manifestation of clinical symptom can be as early as 6 months of life because of protective effect of hemoglobin F. They present with different crises: splenic sequestration, they present with splenomegaly and severe anemia, pain crisis, aplastic crisis because of infection with parvovirus B19. Bacterial sepsis is the greatest cause of morbidity and mortality in children with sickle cell disease. That's why if any child with sickle cell disease presents with fever, this must be taken seriously because of possibility of bacterial infection by encapsulated organism like meningococcus, pneumococcus, and Haemophilus influenza. Functional asplenia as early as 6 months of life and by age of 5 in the most of the children. Laboratory finding in cases of sickle cell disease: anemia, sickle cells in the peripheral smear, target cells, and if you do not see sickle cell in the peripheral smear, you can do sickle prep with metabisulfite. This will make the hemoglobin sickle, especially in the cases of the trait if you do not see any sickling in the peripheral smear. So this will be positive in both the disease and the trait. Hemoglobin electrophoresis will confirm the diagnosis. You will see the hemoglobin S is 90% or more, and in the cases of the trait you will see the hemoglobin S is less than 50%, and usually when hemoglobin S is less than 50%, usually do not sickle except in special circumstances like in the renal medulla. But normally these patients, they are asymptomatic. This is these patients, they are sick all the time because of the predominance of the hemoglobin S. This is a peripheral smear for a child with sickle cell disease. As you see here in this peripheral smear, abnormal shape, red blood cells, needle-like structure or banana-like structure, and also you will see red blood cell with Howell jelly bodies, which is this blue dot in the periphery, because most of the red blood cells will be released from the bone marrow with no nucleus, but some of them will have some remnant of the nucleus, and the spleen will be able to clean that. But because of autosplenectomy, because of abnormally functioning spleen, this Howell jelly bodies will remain, and you will be able to see it in the peripheral smear. So this is represent or means that there is abnormally functioning spleen or splenectomy or autosplenectomy. Also you will see here target cells. As you see here, some of the hemoglobin, because of membrane bleb, accumulate in the middle and of the central pallor, giving you the target appearance. So in sickle cell peripheral smear, you will see sickle cell, as you see here, needle-like structure or banana-like structure, Howell jelly bodies, and target cells. All providers caring for children must be familiar with the management of sickle cell disease. Any infant or a child with history of sickle cell disease presents with fever, must be taken seriously. This is considered medical emergency due to high risk of severe bacterial infection and a high fatality rate. Parenteral IV must be started immediately. IV third generation cephalosporin, cefotaxime or ceftriaxone. Penicillin VK prophylaxis is very important until 5 years of age. 125 mg twice a day until 3 years of age, to 50 mg by mouth twice a day until they are 5 years of age. You continue even additional 2 years if there is a history of encapsulated organism infection. Osteomyelitis is also a common complication with sickle cell disease and frequently caused by staph or salmonella. Management of pain crisis is a strong analgesic, especially in case of moderate and severe pain. Even a bolus of strong opioids to all patients presents with severe pain must be offered. For mild pain, you can offer acetaminophen or NSAID if is not contraindicated. Hydroxyurea to prevent the frequency of the pain crisis. This is usually the hydroxyurea decreases the pain crisis by 50% by increasing the hemoglobin F and total hemoglobin. This usually will be managed by hematologists. The side effects you need to be familiar with is myelosuppression, but this is reversible. You need to be familiar with aplastic crisis and the complication of infection with parvovirus B19. We need to know also that the red blood cell lifespan is shorter than normal cells in the patient with sickle cell disease, And if you cut down or you prevent the production of red blood cell for 10 to 14 days in the patient with sickle cell disease, this can cause profound anemia. This is okay for normal child or normal person to have parvovirus B19 infection, but in case of sickle cell disease, cessation of production of red blood cells for 10 to 14 days, this can cause severe or profound anemia. The clinical presentation: pallor, fatigue, decreased activity, poor feeding, and altered mentation. Laboratory finding in cases of aplastic crisis: severe anemia, reticulocytopenia. So the key here is the retic count will be very low, low bilirubin, occasional thrombocytopenia. Management is transfusion until the reticulocyte recovery has occurred. Splenic sequestration, the etiology is unknown. 30% of children with sickle cell anemia have episodes of significant sequestration. They present with increase in size of spleen, evidence of hypovolemia. So large spleen or enlarging spleen, hypovolemia, decline in the hemoglobin. How to make the difference between splenic sequestration and aplastic crisis? Because both of them, they present with drop in the hemoglobin or severe anemia. In cases of splenic sequestration, the retic count will be high and the bilirubin will be elevated. In aplastic crisis, you will have low retic count and low bilirubin level. This is a key word to differentiate between both cases. Management of splenic sequestration: maintenance of hemodynamic stability and management of hypovolemia, blood transfusion for the anemia, and you need to teach the patient this can occur again, and they need to be familiar, or they need to learn how to palpate the spleen. Dactylitis, very important to be familiar with it. Any infant presents with a family history of sickle cell disease or trait, presents with a swelling in the hand and feet, you must suspect the sickle cell disease because of dactylitis. Presents with a swelling in the hand and feet, often the first manifestation of pain in children. Occurs in 50% of children by 2 years of age with sickle cell disease. Unilateral can be confused with osteomyelitis. The treatment is pain medication, acetaminophen with codeine, for example. Vaso-occlusive crisis is simply pain anywhere in the body. Why? Because of disruption of blood flow in the microvasculature by sickle cells because of irreversible sickling. The risk factors is exposure to cold, hypoxia, acidosis. The clinical presentation: pain anywhere in the body, chest, back, abdomen, or extremities. Management of vaso-occlusive crisis is pain medicine, starting from acetaminophen up to IV morphine depending on the severity of the pain. IV hydration and transfusion do not prevent or relieve the pain. Concern about opioids dependency must not be a reason not to treat a child with pain, but you need to be familiar with the side effect of opioids, for example constipation and respiratory depression. Very important. Priapism is another complication of sickle cell disease. Is a benign erection lasting more than 30 minutes. The treatment is pain medicine, sitz bath. If it lasts more than 4 hours, because this may result in sexual dysfunction, aspiration of blood from the corpora cavernosa, followed by irrigation with diluted epinephrine. This will cause immediate relief. Neurologic complications is the most devastating aspect of the sickle cell disease. Is because of cerebral infarcts. This can present either way, either silent stroke or overt stroke. Silent stroke, the child will present with the cognitive function deterioration, and it will present with a learning disability or a behavioral change. And in overt stroke, they will present with neurological symptoms like headache, seizure, weakness, hemiparesis, and other neurological deficit will depend on the location of the infarct. The diagnosis of neurological complication of sickle cell disease like stroke, it will be MRI with MRA. The treatment is oxygen to maintain saturation more than 96%, transfusion within 1 hour to increase the hemoglobin level to max of 11 gram per deciliter. Prevention of neurological complication, we have primary prevention by screening test, which is the transcranial Doppler, to measure the blood velocity. Prophylactic transfusion is indicated to decrease the hemoglobin S to less than 30% to reduce the recurrence of a stroke. This can start as early as 2 to 3 years of age. Secondary prevention: transfusion therapy after initial stroke, maintain the hemoglobin S less than 30%. Complications of transfusion is iron overload, and this treated with iron chelating agents, phlebotomy, and erythrocytophoresis. It is expensive and complicated. Acute chest syndrome, the clinical presentation: fever, respiratory distress, chest pain, new radio density on a chest x-ray. So it is very important to know any child with sickle cell disease presents with a fever should have a chest x-ray, even in absence of respiratory symptoms. Management of acute chest syndrome is oxygen, indication for simple exchange transfusion, decreasing oxygen saturation, increasing work of breathing, and tachypnea. Antibiotics, macro leads to cover for mycoplasma and chlamydia, third generation to cover for strep pneumonia. Renal complication in the sickle cell diseases: gross hematuria, papillary necrosis, nephritic syndrome, renal infarcts, pyelonephritis, renal medullary necrosis, and proteinuria. General consideration in the patient with sickle cell disease: high risk of academic failure, generally anemia affected the cognitive function, also poor high school graduation rate. Third of the children may have cerebral infarcts, and even they present with silent infarcts and decrease or deterioration of the cognitive function. Other complication of sickle cell anemia is delayed puberty, vascular necrosis of the femoral head, retinopathy. When they go for surgery also, they may develop complication including pain and acute chest syndrome after the operation. So this can be prevented by blood transfusion before surgery to keep the hemoglobin approximately 10 gram per deciliter. Methemoglobinemia. This can be congenital or acquired. Acquired is more common than congenital. The idea of methemoglobinemia is that the heme, it has iron and protoporphyrin. The iron is usually or normally in the reduced ferrous state, able to carry oxygen and make oxyhemoglobin, and this oxyhemoglobin carrying oxygen and easy to release this oxygen to the tissue. In the cases of methemoglobinemia, the iron in ferric state is oxidized, and methemoglobin has inability to carry the oxygen and deliver oxygen to the tissue. So the clinical presentation will depend on the percentage of methemoglobin in the circulation. So if you have 15% or more, you will see visible cyanosis in the skin. Methemoglobin, for example, more than that can present with headache, lightheadedness. If it's between 50 and 70% can present with cardiac arrhythmia or neurological manifestation. More than 70% is lethal and can cause death. Normally, the methemoglobin will make the blood color dark brown. So easy bedside test is to expose the tube of dark blood to 100% oxygen. If it changes the color to be light, this is not methemoglobinemia. If it remains dark, this means that the tube containing methemoglobin. The triggers for that: infection like rotavirus infection, gastroenteritis, water high in nitrites, and aniline teeth gel. Pyruvate kinase deficiency. As you know that the glucose is the source of energy, and the red blood cells requires glucose in order to survive. So the glucose will be broken to pyruvate and lactate. And there is an enzyme is called the pyruvate kinase, will change the phosphoenol pyruvate to pyruvate, releasing one phosphate to change the ADP to ATP, and this ATP is very important for the red blood cells as the source of energy and to prevent premature death. So deficiency of pyruvate kinase you will have less ATP and you will have less energy and early death of the cells and decrease survival of the red blood cells. So this is the idea of pyruvate kinase deficiency. This eventually will cause hemolysis or hemolytic anemia because of a decrease in the red cell survival, because there is no source of energy, or decreased source of energy because of a high ADP instead of high ATP. Clinical presentation: it varies from severe neonatal hemolytic anemia to mild well-compensated hemolysis. Know that this may present with severe jaundice and anemia during the neonatal period. Also, they may present with splenomegaly and aplastic crisis if they have infection with parvovirus B19. Laboratory finding: reduced red blood cell pyruvate kinase enzyme level, elevated retic count because it's hemolytic anemia. The smear or the peripheral smear will show polychromatophilia, macrocytosis, ovalocytes, and acanthocytes. Treatment exchange transfusion may be indicated for hyperbilirubinemia newborn, blood transfusion as necessary, folic acid supplementation. Splenectomy should be performed of frequent transfusion after age of 5 to 6 years. Let's pause a little bit with this clinical scenario. This is a 2-year-old African American boy who is pale and irritable for 3 days after he was given oral Bactrim for urinary tract infection last week. Temperature is 37.3, pulse is 125, respiratory rate is 22, blood pressure is 98/64 mm mercury, physical examination is 2/6 systolic ejection murmur, no hepatosplenomegaly, and laboratory test shows white blood cell count is normal. Hemoglobin is low, is 6.5 gram per deciliter. Hematocrit is low, is 19%. Mean corpuscular volume is 79, so it is normocytic. Platelet count is normal. Retic count is elevated. Direct bili is slightly elevated. Indirect bili is elevated. Direct antiglobulin test or COMS test is negative, so it's not autoimmune. What is the most likely diagnosis? The key point in this case, this is a 2-year-old African American who is pale and irritable, so it start to show signs of anemia after he was given oral Bactrim. The anemia here is hemoglobin is low and hematocrit is low, but is normocytic, is not microcytic. So this will make the thalassemia is unlikely in this case, and also the COMS is negative, and this will make the autoimmune anemia is unlikely in this case. Also, this patient is having jaundice, so is hemolytic anemia. So pale after giving a trigger like oral Bactrim, the anemia is normocytic, not microcytic. The retic count is elevated and hyperbilirubinemia, so is hemolytic anemia, and the COMS test is negative, so it's not autoimmune. So what is the most likely diagnosis? This is a classic presentation of G6PD deficiency. So the keyword here, African American who is pale and irritable, exposure to oxidant drugs, normocytic hemolytic anemia, and a high retic count and hyperbilirubinemia. So this is a classic presentation of G6PD deficiency. Glucose phosphate dehydrogenase deficiency. The idea here that the red blood cells is always exposed to oxidative radicals, for example He2O2. So you have to have G6PD in order to protect the red blood cells. How? By changing the NADP to NADPH. So this NADPH will convert the oxidized glutathione to reduce the glutathione, and reduce the glutathione will protect the red blood cells from these oxidative radicals. So if you have deficiency of G6PD, you will have less reduced glutathione, so the red blood cells will be injured by these radicals and it will cause hemolysis. Pathophysiology of G6PD deficiency is reduced half-life or deficiency of G6PD in the red blood cells. Mildly reduced G6PD, this may not have hemolysis or may not experience hemolysis. Markedly reduced G6PD, this presents usually with chronic hemolysis. This is the patient that are sick most of the time. The idea here that if in the mild cases you will have more new red blood cells with normal G6PD level. So it's very important when you test the patients for G6PD, you need to wait till you have more mature red blood cells with G6PD deficiency. So if you have recent hemolysis, this test G6PD level will give you a false negative result. Genetic test is X-linked recessive, so it presents in boys and the girls are carrier, more common in African American and Mediterranean ancestry. Episodes of hemolysis can be produced by drugs like antioxidant drugs including aspirin, sulfonamide, antimalarials, and usually presents between 24 and 48 hours after exposure. Fava beans, especially Mediterranean infections, and neonatal jaundice by itself also can induce the hemolysis. Laboratory finding in cases of G6PD dehydrogenase deficiency, normocytic anemia, of course jaundice and high level of unconjugated bilirubin and low level of haptoglobin. High antibodies in the peripheral smear. This is very unique about G6PD deficiency and is because of denatured hemoglobin and will require a special stain. It's called supravital stain to be able to see it. And this denatured hemoglobin will be recognized by the macrophage in the spleen, and this macrophage will start to eat this part and will give you bite cells. The confirmation of G6PD deficiency confirmed by reduced G6PD activity in red blood cells. But you should do this test a few weeks after the hemolytic episode. If you do it early, it will show normal activity in the young red blood cells. But you need to wait a few weeks after the hemolytic episode to give you a positive result in cases of G6PD deficiency. Treatment of G6PD deficiency: avoidance of agents, transfusion as needed, folic acid supplementation. Explain to me if there is a severe chronic anemia, hypersplenism, splenomegaly because of risk of splenic rupture in contact sports. Autoimmune hemolytic anemia. Autoimmune hemolytic anemia because of antibodies against the antigen on red blood cell surface. There is two forms, IgG and IgM. IgM against Rh complex is the most common in children. IgM called antibodies usually associated with infection, especially mycoplasma and EBV or Epstein-Barr virus. Clinical presentation: pallor, jaundice, pyrexia, hemoglobinuria, splenomegaly. Laboratory finding in cases of autoimmune hemolytic anemia will be same finding like any hemolytic anemia, but here you will have the direct positive direct antiglobin or COMS test. So antibodies will be recognized destroying the red blood cells. There's something unique about autoimmune hemolytic anemia. They will have high MCHC, mean corpuscular hemoglobin concentration, with spherocytosis. So if you have these two and the positive COMS test is autoimmune hemolytic anemia. High cold agglutinin IgM titer in cases of mycoplasma and EBV. Treatment of autoimmune hemolytic anemia: supportive treatment for mild cases, corticosteroid for IgG mediated disease, blood transfusion, IVIG, splenectomy in persistent cases. Erythrocytosis: uncontrolled production of red blood cell and increased red blood cell mass. The definition is red blood cells 25% more than the upper normal value. There is two types, the primary and secondary. The primary is well known also as polycythemia vera. There is major criteria for diagnosis and minor criteria. Major criteria is increased red cell mass, arterial oxygen saturation more than 92%, and palpable spleen. Minor criteria: platelet more than 400,000, leukocytosis more than 12,000, and increased leukocyte alkaline phosphatase, increased vitamin B12 more than 900 pg per ml, and binding capacity more than 2200 pg per ml. Clinical presentation of polycythemia vera is hypertension, headache, shortness of breath, neurological symptoms like dizziness, vertigo, visual disturbances. Thrombocytosis may cause hemorrhage and thrombosis. Secondary polycythemia: increased hematocrit more than 65%. Clinical presentation: hyperviscosity, headache, and hypertension. Etiology or causes: familial, like for example hemoglobinopathy, hypoxia like high altitude, cardiac diseases, lung diseases, central hypoventilation, hormonal like adrenal diseases, renal like tumor or renal tumor or cysts, renal artery stenosis, and hydronephrosis. Other causes, for example liver like hepatoma, neonatal twin transfusion, infant of diabetic mother, IUGR, trisomies, congenital adrenal hyperplasia. Treatment of erythrocytosis or polycythemia: periodic phlebotomy, if the hematocrit is more than 65 to 70%, or if the hemoglobin more than 23 gram per deciliter. For neonatal polycythemia, observe if asymptomatic. If no symptoms, you can observe, and the hematocrit is less than 75%. You continue monitoring the cardiorespiratory symptoms every 6 to 12 hours. Monitor the level of hematocrit and glucose until the hematocrit level decline. Asymptomatic and the hematocrit level is more than 75% to consider partial exchange transfusion. Symptomatic and the hematocrit level is more than 65, consider partial exchange transfusion. Symptomatic and the hematocrit level between 60 and 65, consider alternative causes other than polycythemia. Must be excluded first. Fanconi anemia is autosomal recessive disease because of mutation in FANC-A and FANC-C genes. Clinical presentation: skin abnormalities, hyperpigmentation, café au lait spots, short stature, upper limb anomalies, absent thumb, triphalangeal thumb. The key word to remember this disease, very important: anemia, especially macrocytic, cafe au lait spots, short stature, triphalangeal thumbs or absent thumb, intellectual disability. Other anomalies in Fanconi anemia: genital anomalies, facial abnormalities, especially microcephaly, intellectual disability, kidney abnormalities like horseshoe kidney, absent or duplicate kidney. Laboratory finding in cases of Fanconi anemia: macrocytic anemia can be associated with pancytopenia with significant decrease in white and red blood cells and platelet because of aplasia. The very important test to remember about Fanconi anemia: deoxybutane DNA analysis. Very important to know that Fanconi anemia puts the patient at risk for cancer, acute leukemia, carcinoma of head, neck, and upper esophagus. Very important to know this risk. Shwachman-Diamond syndrome is very rare. If you forget everything about this disease, remember two things: neutropenia and pancreatic insufficiency. This is the two key words for this disease: neutropenia and pancreatic insufficiency or GI symptoms. It is very rare. Genetically, it is transmitted as autosomal recessive. Clinical presentation: failure to thrive because of fat malabsorption because of pancreatic insufficiency, associated with skeletal abnormalities, short stature, abnormal digits like syndactyly or clinodactyly. Also, this disease can be associated with abnormal face or abnormal facial features, bifid uvula, dental dysplasia, hypertelorism, microcephaly, retinitis pigmentosa, and recurrent bacterial infections. Laboratory finding in this disease: abnormal pancreatic enzyme and steatorrhea. Absence of steatorrhea do not rule out this disease. Neutropenia, bone marrow hypoplasia, pancytopenia in 60% of the cases. Diagnosis: mutation analysis for Shwachman-Diamond Diamond syndrome gene. This is the definitive diagnosis in 90% of the cases. We have to be familiar with the possible complications associated with Shwachman-Diamond syndrome. These complications increase with age and usually after 10 years of age. These complications: aplastic anemia, myelodysplastic syndrome, acute myelogenous leukemia. So this disease increases the risk of cancer. Treatment is granulocyte colony stimulating factor. This can improve the neutropenia, but the problem will accelerate the risk of myeloproliferative disorders. Pancreatic enzymes and fat-soluble vitamins, androgen with low-dose prednisone. I will point out some very important keyword when you are presented with a peripheral smear: hypersegmented neutrophil, 6 or more lobes. This is indicative of megaloblastic anemia, and this can be seen in B12 or folic acid deficiency. Howell Jolly bodies, which is nuclear remnants, should be removed by the spleen, and when there is no spleen or functional asplenia, this nuclear remnants will be seen in some of the red blood cells in the peripheral smear and will known as Howell Jolly bodies. Heinz bodies is denatured hemoglobin, commonly seen in cases of G6PD deficiency. Schistocyte is mechanically fragmented red blood cells, looks like a helmet or the helmet of the firefighter, and this is because of injury of the endothelium, as in cases of DIC, TTP, and HUS. Spherocytes is because of loss of membrane and abnormality in the cytoskeleton of the red blood cell. Instead of biconcave shape, it will look spherical. So this can be seen in congenital spherocytosis, autoimmune hemolytic anemia, enzymopathy, and abnormal hemoglobin. Target cells is because of excess membrane, and there is a blip, and the hemoglobin from the periphery will collect in the middle of the central halo or central pallor and will look like target appearance or target cells. This is commonly seen in cases of thalassemia. We'll discuss in this section the non-neoplastic disorder of the white blood cells. Neutropenia. Neutropenia means a decrease in the white blood cell count. Whenever you see a patient with decrease in white blood cell count, you need to calculate the absolute neutrophil to be able to classify it. So absolute neutrophil count, how to calculate? By adding the 6 to the immature white cells like bands. So percentage of the 6 plus the percentage of the bands time the white blood cell count. Mild cases of neutropenia means that the ANC is 1000 to 1500. Moderate cases or moderate neutropenia means that the ANC is 500 to 1000. Severe cases, the ANC will be less than 500. Risk of infection, when white blood cells rises, the risk of infection decreases even if the patient is still neutropenic. Causes of acute neutropenia: viral infection, for example EBV infection or RSV, or human herpes virus 6 infection like in cases of roseola. Bacterial infection, hypersplenism, can be induced by drug, and once you stop the drug, the white blood cell count will go up to normal again. For example Bactrim, analgesic medication like ibuprofen. So very important to know the causes of acute neutropenia. Cyclic neutropenia is a rare cause of chronic neutropenia, very rare. It is autosomal dominant because of mutation neutrophil elastase expressed gene. Clinical presentation: they present with neutropenia in cycles. So neutropenia occurs every 21 days and lasts for 3 to 6 days. And severe neutropenia can occur during nadir, which is the lowest point of neutropenia. And this can be associated with fever, oral ulceration, gingivitis, pharyngitis, and skin infections. Cyclic neutropenia may present with more serious infection like pneumonia, necrotizing enterocolitis, or sepsis. The count when you do the CBC may be recovering when brought to medical attention, so it will be not easy to diagnose. In order to diagnose this condition or to discover the cyclic pattern of the neutropenia, you need to do CBC 2 to 3 times per week for 6 weeks. The treatment: prophylactic granulocyte colony stimulating factor during nadir in some cases. Immediate attention with fever. When the patient they have fever, they have to be seen immediately. Chronic benign neutropenia typically presents less than 3 years of age. No serious infections associated with this form of neutropenia. Has to be differentiated from serious form of neutropenia because it's a diagnosis of exclusion. No treatment is necessary except paying attention to fever. Autoimmune neutropenia is more severe. ANC might drop down to 0. Usually these patients, they have positive anti-neutrophil antibodies. However, absence of these antibodies do not rule out this disease. Focus on the treatment of intercurrent infection with antibiotics. Prophylactic Bactrim if frequent infections. G or granulocyte colony stimulating factor will decrease the frequency of infections in children with recurrent infection. Spontaneous recovery expected or typically between 6 months to 24 months is typical in this condition. Costman syndrome or severe congenital neutropenia. This is autosomal recessive because of mutation in neutrophil elastase gene. It is very rare. It is very aggressive. Clinical presentation: mouth ulcers, gingivitis, otitis media, cellulitis, respiratory infections. Also can present with skin infections and abscesses. This is the most common presentation. Pneumonia, deep tissue infections, and often life-threatening. Mild hepatosplenomegaly. It may progress to myelodysplastic syndrome or leukemia. Treatment is granulocyte colony stimulating factor stem cell transplant for cases of leukemia. Platelet disorders. Congenital megakaryocytic thrombocytopenia. From the name, it is a decrease or deficiency in the platelet because of absence of megakaryocytes. It is autosomal recessive, very rare disease because of congenital absence of megakaryocytes. So in the bone marrow, from the original cells, the hemoblast, the hemocytoblast, the megakaryoblast will arise, and the megakaryoblast should be converted to a megakaryocyte, which is a very large cell, about 10 to 15 times larger than the red blood cell with lobulated nucleus. It will be converted to thrombocyte, which is the platelet responsible for thrombosis and making clots. So if there is an absence of the megakaryocytes, will be no thrombocytes. So these patients, they will present with bruising or bleeding at birth from day one. at least in the first month of life they will present with bleeding. Also, this disease associated with other or can be associated with other anomalies, neurologic like cerebellar or cerebral atrophy, cardiac like ASD, VSD, other anomalies like skeletal abnormalities. Diagnosis: initially absent megakaryocyte, then pancytopenia. If beyond neonatal period, bone marrow aspirate and biopsy will confirm the diagnosis. Thrombocytopenia, absent radius syndrome or TARS syndrome. This is a very rare autosomal recessive disease, but very common to see it in the pediatric board examination. Clinical presentation: thrombocytopenia, absent radius. This is the key word for this disease. Low platelet and absent radius. Congenital heart disease can be seen with this disease. Tetralogy follow, ASD or VSD. Other abnormalities: eosinophilia, milk protein allergy, leukemoid reaction or transient elevation of white count, intellectual disability. The outcome of this disease, very important to know that thrombocytopenia improve with time, especially in the first year, and the transfusion support for bleeding or for surgery. Other causes of thrombocytopenia because of platelet destruction. This can be immune or non-immune. Immune means destroyed by antibodies, like in cases of idiopathic thrombocytopenic purpura or medications. Non-immune, like in case of thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, DIC infection, cardiac, like for example artificial valve. Idiopathic thrombocytopenic purpura. The etiology is antiplatelet antibodies. Autoimmune. Idiopathic means nobody knows why. Often a few weeks after infection, like upper respiratory tract infection. Clinical presentation, you have to know that this presents in very healthy appearing children. They don't have any problem, but suddenly they will start to show some petechiae, and when you do CBC, you will see the platelet count is very low. Ecchymosis and epistaxis, they may present with nosebleed. The major risk here is very important: intracranial hemorrhage. Diagnosis of ITP is from the history. Typically, a healthy child presents with petechiae or nosebleed. And if you do the CBC, you will see the platelet count is low, thrombocytopenia with normal red blood cells and white blood cells. So only one cell line is affected, the platelet, but the red blood cells and white blood cells are normal. And if you look at the peripheral smear, you will see between normal size and increased size of the platelets. No excess of red cell fragments, no abnormal red blood cells, and no schistocyte. So this is typical in cases of ITP. Treatment of ITP is observation. No contact sport is very important to prevent intracranial hemorrhage. No ibuprofen, no aspirin or drug affects the platelet activity. 85% resolve in 6 months. So no treatment is necessary other than reassurance and giving the patient the instructions. Treatment for symptomatic patient with bleeding, typically if it's less than 10,000. If the platelet count is less than 10,000, in this case IVIG, especially if they are anemic and Rh negative. Anti-D if they are not anemic and Rh positive and COMS negative. Steroids, good response, but the side effects and also the problem may mask the diagnosis if there is any other underlying problem. Platelet transfusion is contraindicated unless life-threatening bleeding is present, so actually doesn't work. Platelet transfusion is a wrong answer for ITP. Splenectomy if is more than 4 years of age with severe ITP longer than 1 year. Hemolytic uremic syndrome is not because of antibodies. It's because of injury to the endothelium of the blood vessels because of exposure to furious bacteria, for example, E. coli 157 or Shigella. Clinical presentation usually presents in young children between 4 months to 2 years of age when they have, for example, diarrhea, bloody diarrhea and vomiting, and suddenly they start to have less urine, hypertension and renal failure. Laboratory finding in cases of hemolytic uremic syndrome: thrombocytopenia, very low platelet, anemia can be severe, peripheral smear you will see the schistocytes because of microangiopathy, elevated BUN and creatinine, uremic, urinalysis may show mild proteinuria, red blood cells and red blood cell casts. Stool culture is important. Treatment of HUS is mainly supportive. Maintain fluids and electrolytes, control blood pressure, aggressive management of renal failure, correction of anemia with transfusion. Antibiotic use is not clear. for Shiga toxins. Avoid antibiotic unless the patient is septic. Thrombotic thrombocytopenic purpura. This is a congenital or acquired disease. Is because of ADAM TS13 gene mutation or autoantibodies to break or against this molecule ADAM TS13. What happens when you have decrease in ADAM TS13? This will cause lack of plasma protease, which is very important to break down this large multimers, von Willebrand factor. And if you have accumulation of large multimers of von Willebrand factor, this will cause microangiopathy and endothelial injury in the blood vessels and subsequent thrombocytopenia. Clinical presentation of TTP is PINTAD is 5 things. You will see microangiopathic hemolytic anemia with schistocytes in the peripheral smear, low platelet thrombocytopenic purpura, neurologic abnormalities, fever, and renal disease. Laboratory findings suggestive TTP is thrombocytopenia, DIC, peripheral smear. It may show basophilic stippling. Schistocyte is very important finding. Microspherocytes and nucleated red blood cells, elevated von Willebrand factor antigen. Severe deficiency of ADAM TS13 activity is very helpful in the diagnosis of TTP. Reduced haptoglobin, hemoglobinuria, and hemosideruria. This is very important to be able to recognize the shape of the schistocytes, because this can be seen in cases of TTP, HUS microangiopathy. As you see here, you will see this is a schistocyte, looks like a helmet, a firefighter helmet, and also this is another one with pointing end is abnormal shaped red blood cells, and also you will see in the peripheral smear nucleated red blood cells and also some target cells. Management of TTP is plasmapheresis, rituximab, vincristine, or cyclophosphamide. Platelet transfusion can make neurological manifestation worse. So platelet transfusion is the wrong answer for TTP. This is a 2-month-old boy presents with rash and bloody diarrhea. He drinks 24 to 32 ounces of cow's milk formula per day. Height and weight are normal. His temperature is 38.2 Celsius. Pulse rate is 120, respiratory rate is 24, blood pressure is normal. On examination, the infant is fussy but consolable. There are petechiae on the face and waist, and also erythematous dry maculopapular patches on the cheek and extremities. Tympanic membrane is red and bulging. No anal fissures. The rest of the exam is normal. White count is normal. Hemoglobin is normal. Mean corpuscular volume is normal. Platelet count is low. And the size of the platelet is small. What is the most likely diagnosis? The key word for this disease: bloody diarrhea, eczema, low platelet count, and small size platelet. So bleeding, eczema, small size and low platelet count, and recurrent infections. So this is a classic presentation of Wiskott-Aldrich syndrome. Wiskott-Aldrich syndrome is X-linked because of genetic defect in the WAS protein. Occurs only in males, is X-linked. Clinical presentation: petechiae, spontaneous nosebleeds, and bloody diarrhea. This is very common presentation. Thrombocytopenia, small sized platelet. This is a key word. Eczema, recurrent infections, low IgM and elevated IgA and IgE. Stem cell transplant is curative. Bernard-Soulier syndrome, the idea of this disease that deficient or absent receptors to the von Willebrand factor. So deficient or absent glycoprotein 1b9-5, and when there is an injury, the von Willebrand factor will not be able to combine to the platelet to form a clot because of the lack of the binding protein or receptor. It is autosomal recessive, causing severe platelet dysfunction associated with thrombocytopenia and giant platelets. This is a key word for this disease, and markedly prolonged bleeding time. Glanzmann thrombocythemia is autosomal recessive, is abnormal function of glycoprotein 2b and 3a complex, which is the fibrin receptor. It will be associated with severe platelet dysfunction and prolonged bleeding time. The platelet count will be normal. Aggregation study will show abnormal or absent aggregation. The treatment is platelet transfusion. Another, to take a chance, will mention this syndrome, Hermansky-Podak syndrome. is common in Puerto Rican, associated with albinism or oculocutaneous albinism and moderately severe bleeding. Kasabach-Merritt syndrome is a vascular tumor, can be associated with thrombocytopenia, hemolytic anemia, and coagulopathy, as opposed to the infantile hemangioma, which regress over time in the first few years. This tumor do not regress spontaneously, especially the Kaposi-form hemangioendothelioma. And this tumor is localized tumor, however, can be very aggressive. So this tumor do not metastasize. This tumor also can be fatal. For any infants who presents with unexplained thrombocytopenia, you should keep the vascular tumor in differential, because this tumor can be easily identified under the skin, but also can be hidden in the viscera, for example in the spleen. So very important to keep in differential for any infants who presents with unexplained thrombocytopenia, because this can be fatal. Coagulation disorders. Hemophilia is X-linked recessive, primarily occur in boys. Girls are typically asymptomatic carriers. It is because of factor 8 deficiency and is well known as Hemophilia A. This is the most common, or factor 9 deficiency and is well known as Hemophilia B, and this is less common. Bleeding may start after birth, especially after circumcision. Classifications, you need to know the normal value of factor 8 assay, which is 50 to 150%. Severe hemophilia occurs when factor 8 is less than 1%. Moderate hemophilia occurs when factor 8 1 to 5%. Mild hemophilia occurs when factor 8 is more than 5%. Clinical presentation: easy bruising, intramuscular deep hematomas, which will present as localized pain and swelling. Hemarthrosis is a very important problem in cases of hemophilia. This is the hallmark of the hemophilia. Ankle is the most common joint affected. Knee and elbow increase in frequency with age because of mobilization and sports. Laboratory finding PTT is usually 2 to 3 times the upper limit of normal. So you will see it 90, 100, not just 31 or 32 or 35. It will be a big number. PET, bleeding time, and the platelet count are normal. Specific assays for factor 8 and factor 9 will confirm the diagnosis. Treatment of hemophilia: factor replacement. Mild to moderate bleeding, raise the factor to 35 to 50%. Severe or life-threatening hemorrhage, raise the level to 100%. So by giving factor 8. Lifelong prophylaxis usually started with the first joint hemorrhage. DDAVP may be sufficient in mild form of hemophilia. Avoidance of high-risk behavior like contact sports. Complication: severe hemorrhage and arthropathy. This is a major complication, arthropathy. Van Willebrand disease. The key word for this disease: when you have a personal history of recurrent prolonged mucocutaneous bleeding, for example epistaxis or menorrhagia, excessive and prolonged menstrual bleeding. Also family history of mucocutaneous bleeding. So when you have these keywords, the next step is to do Van Willebrand factor assay activity or Van Willebrand disease panel. So what is the Van Willebrand factor does? It promotes the adhesions and aggregation of the platelets. So this will cause aggregation and prevent bleeding. So when you have deficiency of this factor, Van Willebrand factor, this will decrease the platelet adhesion and aggregation and subsequent bleeding. This factor is stored in the endothelial cells and platelets. So when there is an injury, this will be released and promote the platelet adhesion and aggregation. Also very important to know that this factor is a carrier protein for factor 8. So whenever you have decrease or deficiency in the Van Willebrand factor, this will decrease the activity of factor 8. So also after knowing that this is stored in the endothelial cells, so you have to know that stress or surgery or exercise may transiently elevate the Van Willebrand factor in a patient with deficiency of Van Willebrand factor or patients with Van Willebrand disease. This is what will make it difficult to diagnose. So a repeated assay of Van Willebrand factor activity is important for the diagnosis of you highly suspect this disease from the clinical history and from the family history. Types of Van Willebrand disease. Type 1 is the most common, is autosomal dominant, is because of partial deficiency of Venvel-Brand factor, 75% of the cases, presents with mild to moderate risk of bleeding. Very important to know that Venvel-Brand factor activity in type 1 may not be low enough to lower the factor 8. So if you do PTT, the PTT will be normal. So normal PTT do not rule out this disease. Very important to know that. Also, even normal Venvel-Brand factor activity do not rule out this disease because of transient elevation during stress. Type 3 is the easiest to diagnose because of the severity, is autosomal recessive because of absence of Venvel-Brand factor, and this presents with symptoms similar to hemophilia and prolonged PTT because of severe deficiency of factor 8. Type 2 is the most difficult to diagnose. Clinical presentation of Venvel-Brand disease now is easy to figure out. Is mucocutaneous hemorrhage, for example, excessive bruising, epistaxis, prolonged and excessive menstrual bleeding, post-operative bleeding like excessive bleeding after tonsillectomy or after tooth extraction. Females more commonly diagnosed than males because of menstruation and menorrhagias. Any menstruating female with iron deficiency because of excessive and prolonged bleeding should have detailed history, especially family history and personal history of bruising and excessive bleeding. You have to know that stress like surgery or exercise doubles or triples the level of Venvel-Brand factor, so it is sometimes difficult to diagnose it depending on the laboratory. Diagnosis of Venvel-Brand disease can be very challenging because all these labs can be normal. So PTT often prolonged but frequently normal in type 1, which is the most common type. PT is normal, so PT is not a study for Venvel-Brand disease. So this will be normal because Venvel-Brand factor does not affect factor 7, so the PT will be normal in this disease. Venvel-Brand factor antigen can be measured. Venvel-Brand factor ristocytine cofactor assays. This is the best study to order if you have only one choice. So this will be the study of choice. The factor 8 activity is included in the panel. So if it's prolonged, will be very helpful in the diagnosis. The clinical criteria for the diagnosis of Venvel-Brand disease: personal or family history of mucocutaneous bleeding, physical evidence of mucocutaneous bleeding, and Venvel-Brand factor activity assay, which is the Venvel-Brand factor ristocytine cofactor activity, just same thing, is less than 30. So this is diagnostic, and also this will be confirmed when you give DDAVP and the patient responds. This will be also diagnostic and therapeutic as well. So you have to know there is no criteria to preclude the diagnosis of Venvel-Brand disease. So if you have a strong family history of mucocutaneous bleeding with mild decrease in Venvel-Brand factor 30 to 50, this is suggestive or should raise the concern about Venvel-Brand disease. Treatment of Venvel-Brand disease based on the subtype and the trial of DDAVP. So type 1 usually treated with DDAVP. This is the most common type. DDAVP dose is 0.3 microgram per kilo. This should increase the level of Venvel-Brand factor and factor 8 3 to 5 fold. So documentation of these levels after starting the therapy is very important. Type 2B and 3 primarily treated with concentrate of factor 8 and Venvel-Brand factor. Platelet type usually treated with platelet transfusion. Factor 12 deficiency. It is rare autosomal recessive. The PT will be normal or prothrombin time will be normal and will be associated with very prolonged PTT. No clinical bleeding, however, only significant for laboratory testing. May have a prothrombotic effect, so they may cause thrombosis. Abnormal lab only, no symptom. This is the key word for this disease. All labs are normal except PTT. And this will make the difference between this disease and factor 8. Factor 8 is associated with bleeding. There is no bleeding with this disease. It's just an abnormal lab. Factor 13 deficiency. Factor 13 is important to cross-link the fibrin to make the clot stronger. So they do make clots with no problem, but because of deficiency of factor 13, the clot is not strong, so they bleed afterward. So it is autosomal recessive. The clinical presentation: bleeding from umbilical cord or circumcision. This is very common presentation 12 to 24 hours later. So they make the clot, but the clot is not strong, then they start to bleed afterward. Laboratory uroglobulin lysis test. The treatment is fresh frozen plasma and factor 13 concentrate. DIC or disseminated intravascular coagulopathy or coagulation. The etiology is widespread of intravascular consumption of platelets and the plasma clotting factors and deposition of fibrin. Clinical presentation: bleeding from venipuncture site, petechiae, ecchymosis, clot formation. Common conditions associated with DIC trauma, especially cranial burns, venom or snake bites, malignancy, infection, sepsis, immune complexes, obstetrical emergencies, for example, eclampsia, oral contraceptive, and giant hemangioma. Laboratory finding in cases of DIC: prolonged PT and PTT together, decrease the fibrinogen, decrease the platelets, increase the fibrin degradation products, and D-dimers. Because of endothelial injury and thrombosis, you will see helmet and schistocytes. Remember, schistocyte can be present in TTP, DIC, and HUS. Treatment of this disorder, DIC, treatment of the underlying disorder. If there is sepsis, you need to treat the sepsis. Replacement therapy of the components as indicated. Thrombophilia means a child presents with a clot. The causes of that either inherited or acquired. Inherited: protein C deficiency, protein S deficiency, antithrombin deficiency, and factor-laden mutation. Acquired, like in cases of cancer, antiphospholipid antibodies, central venous catheter. Blood transfusion. The most common form of blood we use for transfusion is packed red blood cells. Packed red blood cells, the dose is 10 to 20 ml per kilo. The rate is 5 ml per kilo per hour for healthy children. Everybody should receive white blood cell filter to decrease the rate of infection with CMV and incidence of fever. Immune compromised patients, they should receive irradiated cells to prevent graft versus host disease. Common complications with blood transfusion: fever, this is the most common reaction, allergic reaction like urticaria or anaphylaxis. Fresh frozen plasma indications is volume replacement and replacement for coagulation factor, especially if there is no specific diagnosis. This is the end of this presentation. Thank you for listening.
Having trouble or trying to pass the pediatric board exam? We have the definitive solution for you, presenting the Last-Minute Review Series, a powerful tool for achieving success in pediatric board exams, crafted by Dr. Osama Naga, a board-certified pediatrician by American Board of Pediatrics and the editor of the Pediatric Board Study Guide, a last-minute review. Dr. Naga breaks down the most critical subjects in this series. The Pediatric Last-Minute Review webpage offers a thorough and rigorous set of pediatric board review sessions that are in line with the study guide. The lectures will cover the most important topics for each condition that a pediatrician must know for pediatric board exams, as well as real-life clinical encounters. The inclusion of a clinical case scenario, accompanied by multiple-choice questions, followed by the most probable answer and a comprehensive description of the issue, will ensure test readiness for each student. You will be able to download the lecture's PDF files to make your studies easier, to take notes and be accessible on the go and offline. Based on the membership plan you choose, you will have unlimited access to the lectures for either 1 month, 3 months, 6 months, or 1 year. By viewing these videos, you will increase your chances of passing the board exam and gain substantial advantages from the acquired knowledge. Additionally, by studying the material and completing the AAP prep questions from the previous 3 years, you will greatly increase your likelihood of passing the board and will acquire a wealth of knowledge. Click on the link provided below to visit lastminutepediatric.com and subscribe immediately. Be sure to take advantage of our free video samples on our YouTube channel, Pediatric Board Last Minute Review. Good luck with your exams.
This lecture is only for educational purpose and not intended to direct care of any specific patient. Please consult your physician and the physician of your child for the correct diagnosis and the proper treatment. None of my videos can be superior or an alternative for the opinion of an experienced and licensed healthcare professional. Thank you again.